recognizing the Nacotchtank and Piscataway people, the first residents of the land that would become the District of Columbia. Every community owes its existence and vitality to generations from around the world who contributed their hopes, dreams, and energy to making the history that led to this moment. Some were brought here against their will, some were drawn to leave their distant homes in hope of a better life, and some have lived on this land for more generations than can be counted. Truth and acknowledgement are critical to building mutual respect and connection across all barriers of heritage and difference. We begin this effort to acknowledge what has been buried by honoring the truth. We stand on the ancestral lands of the Nacotchtank and the Piscataway people. We pay respects to their elders past and present. Please take a moment to consider the many legacies of violence, displacement, migration, and settlement that brings us together here today. We aim to hold ourselves and the university community accountable to tribal nations.
Instead of tolerating everyday tragedies as inevitable or someone else's problem,
smoking will be banned in almost every workplace.
Public health leaders find ways to prevent them.
Behind it all are years of development and hope.
Not for money or for fame.
For this AIDS patient, AZT is a wonder drug.
An innovation in medicine is precision medicine.
But to save lives, millions at a time.
Don't be scared. If I do that, you can do too, okay?
Since 2017, the Bloomberg American Health Initiative has been training a new generation of public health leaders.
My name is Belina Shaw, and I'm a Bloomberg Fellow.
My name is Aneri Patani, and I'm a Bloomberg Fellow.
I'm a Bloomberg Fellow.
I'm a Bloomberg Fellow.
I'm a Bloomberg Fellow.
I'm tackling addiction and overdose in Pittsburgh, Pennsylvania.
Adolescent health in Washington, D.C.
Environmental challenges
in Washington, D.C.
Food systems for health in Indianapolis, Indiana.
I'm tackling human trafficking and sexual violence in Minnesota.
Across America, Bloomberg Fellows are on the ground tackling some of our most pressing health challenges.
As of today, we have 388 Bloomberg Fellows working across 43 states, including Washington, D.C., and 2 territories.
The rapid rehousing program that I started was evaluated and found to reduce both housing instability and future violence for survivors.
We make sure that kids have access to the healthiest food available inside their school building.
I see my work impacting the community when I see new crisis systems and services being developed all across the country.
If I could say anything to our Bloomberg Fellows, it would be our future depends on all that you're doing. And it's critically important at a time when the landscape is changing.
This is a moment in this country where we know that we are deeply polarized. Let's do the work of public health, of focusing on the evidence, of building coalitions, of finding pragmatic policy, and show people that together we can extend American life expectancy.
Public health considers the big picture.
Public health gives us the tools to chart a path forward.
Public health is boots on the ground to improve health and quality of life for all Americans.
Public health is taking care of each other. Is safety. It's a human right.
It's an ever-changing field.
It's community.
It's the love of all people.
Public health is everywhere.
The public health policies we support today will determine what kind of world we leave for our children and grandchildren.
Public health has never been easy. What makes it successful over time is not just the skills that we have or the tools that we have, but the fact that we do it together.
Public health is us.
Good morning, and welcome to the 2024 Bloomberg American Health Summit. Please welcome Michael R. Bloomberg.
Hello. Well, good morning, everyone, and welcome to the Washington, D.C. 7th Annual Bloomberg American Health Summit. Now, for those of you who participated in the photo line, here's the numbers. 176 fellows took pictures in 13 minutes. I learned that I am not the tallest, not the shortest, thank you, but definitely the oldest. Anyways, let me thank Ron Daniels as well as the leadership of the Johns Hopkins Bloomberg School of Public Health, Josh Sharfstein and Michelle Spencer, and a special thanks to Dean Emeritus Al Sommer and current Dean Ellen MacKenzie. You should know that Ellen's time as Dean is winding down, and for all of the incredible work that she's done, let's give her a big round of applause. Now, I graduated from Johns Hopkins University 60 years ago. That's the class of 64, if anyone's trying to do the math. I think it's fair to say I spent as much time organizing fraternity dances as I did in the library. And if I had told my professors that one day the public health school would bear my name, they would have laughed me out of class. Of course, back then, if I had also said that one day someone who opposes vaccines for deadly diseases would be nominated to run the Department of Health and Human Services, they would have laughed even harder. But sadly and shockingly, as we all know, it is no laughing matter. When I was growing up, one of the biggest fears parents had was that their children might contract polio. I remember the cover of Life magazine showing a gymnasium full of iron lungs with people having their heads sticking out, looking helplessly at the camera. The disease paralyzed and killed thousands of people before the vaccine was introduced in 1955. Thanks to that vaccine and others, polio and other diseases like measles and mumps are now exceptionally rare. Before vaccines, 500,000 people contracted measles every year, and 10% were hospitalized. 200,000 got diphtheria every year, and some 15,000 of them died. In fact, over the past half-century, vaccines have saved the lives of millions of Americans, especially children. And making it harder to get vaccines will be one of the most catastrophic mistakes in American history, a travesty beyond measure. I'm hopeful that Senate Republicans will convince President-elect Trump to rethink the nomination of Robert Kennedy Jr., and the president has good reason to rethink it. After all, Kennedy has attacked what may be President Trump's biggest first-term accomplishment, something called Operation Warp Speed, the federal effort to fast-track development of a vaccine for COVID-19. It saved millions of lives, allowed the economy to reopen, and helped Americans get back to their normal routines, and it continues to do that. President Trump does deserve real credit for Operation Warp Speed, yet Kennedy has made the outrageous false claim that it was, quote, the deadliest vaccine ever made, and that it, quote, may have caused more harm than good. In reality, studies show the vaccine saved some 20 million lives. Now, just imagine if RFK Jr. had been in office during Trump's first term. Would Operation Warp Speed have even happened? And if it did, how long would the vaccines have been delayed? How many fewer people would have gotten the shot? How many more people would have died? How much more damage would that have done to our economy? All we can say for sure is this: it would have made COVID even more deadly and even more economically painful. And so the question now is, how much worse might the next pandemic be under a Secretary Kennedy? Sadly, the reality is the next one may already be on our doorstep. Thankfully, the H5N1 bird flu and Mpox viruses, which are deadly, remain fairly isolated for now. But whether it's those viruses or a different virus that emerges, the next pandemic isn't a question of if, it's a question of when. We need government leaders who are capable of preparing and responding effectively, including by supporting the development of new vaccines. Putting RFK Jr. in charge of that would be beyond dangerous. It would be medical malpractice on a mass scale. Now, I understand the frustration that parents felt around school closures, and I shared it. Thanks to the outrageous opposition of the teachers' unions to reopening schools, too many schools stay closed for far too long, and children paid a terrible price. But as bad as that was, the price children would pay if resistances to vaccines or inability to access them become commonplace, that would be far, far worse. Parents who have been swayed by vaccine skepticism love their children and want to protect them. And we need leaders who will help them do that, not conspiracy theorists who will scare them into decisions that will put their children at risk of disease and even death. Kennedy has said that when he's hiking and passes people on the trail with kids, he tells them, quote, "Better not get them vaccinated." Well, if parents listen to him, their children are more likely to become severely sick or even die. I remember in 2019 when an incorrectly prepared vaccine for measles led to the death of 2 children in Samoa. Kennedy traveled there, and he and his organization fanned the flames of fear and misinformation. As a result, vaccine rates dropped, and more than 5,700 people contracted measles. Tragically, 87 people, most of them children, died. Just think of the parents of those children and the suffering they are still feeling. And now think of what a similar situation would look like in the United States. In Samoa, vaccine hesitancy killed 87 people out of a population of 200,000. If we applied that percentage to the US, the death toll would have been about 150,000 people, most of them young children. It's beyond comprehension that we could inflict this kind of damage on our own nation, our own communities, our own families. And already we are seeing glimpses of the dangers in places like Michigan, where surges in whooping cough cases are the result of declining vaccination rates. Kennedy's attacks on vaccines are part of a worldwide view that sees conspiracy everywhere and can't be bothered with facts. He still claims that vaccines cause autism, even though an abundance of data makes it clear that they don't. He's also said that antidepressants cause mass shootings and exposure to Wi-Fi damages the brain, and that the water vapor airplanes leave in their wake is actually a top secret chemical spray used for nefarious purposes. It's all nonsense with no evidence whatsoever, but he doesn't care about evidence. And that's the real danger, because it's one thing to joke about the way some people call lies alternative facts and actual facts fake news. But when reality is reversed on vaccines and medicine, when people are led to believe that what is up is down, what is dangerous is safe, and what is safe is dangerous, many, many people will die. As bad as that scenario is, it gets worse, as Secretary Kennedy could slow or stop approvals of new treatments and vaccines, and even try to revoke approvals already granted. He could encourage litigation against vaccine manufacturers, and by doing so, discourage investment in new cures. And he could allocate research dollars away from life-saving work and towards junk science. As this group knows, Project 2025 calls for research funding to be distributed through block grants to states, rather than going to universities and research institutions that are leading the most promising work. If we allowed research money to be doled out like political pork and for pseudo-scientific theories, then America will forfeit its place as the best country in the world for medical research, and millions will die early. And we can't afford to let that happen. The COVID vaccine that Trump championed is a case in point. The success of mRNA has opened up immense promise in the fight against other diseases. And as a result, medical researchers are applying this science to improve more and save more lives. And this group helps make all of that possible. Now, I've heard a few Democrats express some sympathy for Kennedy because he has been critical of the junk food and processed food industries. But we don't need to choose between someone who is pro-healthy food and pro-vaccine. Americans deserve both. And let me tell you, you're not going to find anyone who has more scars from battling the junk food and processing food industries than I do. Just try to tell them they shouldn't drink. In City Hall, we banned trans fats over industry opposition. We pushed the industry to reduce salt in foods, and we won. We fought the fast food chains to put calorie counts on menus, and we won. And we took on the soda industry with a plan to reduce consumption of sugary drinks. Those battles and others we fought are reasons why the life expectancy of New Yorkers increased by 3 years during our time in office. They were lonely battles, but we fought them to save and improve lives, and we are still fighting them through the work of Bloomberg Philanthropies and through my role as the World Health Organization's Global Ambassador for Non-Communicable Diseases. Over the years, Bloomberg Philanthropies has invested a great deal of money to prevent non-communicable diseases like diabetes and heart disease. But if the federal government steps back from vaccines, all of that progress will vanish. How many Americans will needlessly and tragically die from infectious diseases is anyone's guess. 100,000, 1 million, 2 million? And if the federal government starts reallocating science funding to nutty conspiracy theories, how many years will that set back a cure for cancer and leukemia and ALS and Alzheimer's and Parkinson's and every other disease that needs more funding? It boggles the mind that the Senate would even consider giving Kennedy any power whatsoever over American health policy. Whatever one may think of his positions on food policies, it's nowhere near enough to overcome his opposition to vaccines. A Secretary Kennedy would set back the goal at the heart of our work together, helping American live longer and healthier lives. We started the Bloomberg American Health Initiative back in 2016 to combat the decline in life expectancy our country was experiencing. We set out to focus on the most pressing threats to American health and addiction and drug overdoses, adolescent health, environmental challenges, obesity, and gun violence. We've made some important progress in each of those areas, thanks in no small part to everyone here today, including our Bloomberg American Health Fellows as they work towards their master's or doctorate degrees. For example, our fellows have conducted research that has helped pass gun safety measures in 21 states, including red and purple states, which is keeping guns out of the hands of potentially violent people. For example, in Minnesota, our fellows are tackling domestic violence against Black women and girls, who make up just 7% of that state's population, but sadly, 40% of domestic violence victims. In coordination with state legislators and activists, they helped create the nation's first ever office dedicated to tackling this crisis. I'd like to ask all the fellows in this room who are working hard to make a difference across America to please stand up. And let's give them a big round of applause. Come on, stand up. Thank you. To help put the state of American health in context, the Bloomberg American Health Initiative is releasing a study today that compares life expectancy in the US to the UK. In the UK, people live about 2.7 years longer, and men live 3.5 years longer than they do in the United States. Researchers found that these gaps can be explained by 4 preventable causes: cardiovascular disease, drug overdoses, motor vehicle crashes, and guns, the very issues our work focuses on. And we know we have a long ways to go. Despite having the world's largest economy and most advanced healthcare facilities, America still ranks 40th in the world in life expectancy. Think about that, 40th down the list. Can anyone imagine the national uproar that would have occurred if America had finished in 40th place in the Olympic medal count? People would have been up in arms, seriously. And every elected official would have been calling for heads to roll and policies to change. But when we finish 40th in life expectancy, they hardly utter a peep about most of the main causes. It's hard to say which is more disgraceful, finishing 40th or having leaders shrug their shoulders about it. And just imagine how much farther we will fall if Kennedy is confirmed. We can't allow Kennedy or Trump or anyone else to bring unimaginable suffering to the American people. So if the president-elect doesn't reconsider the nomination, the Senate has a duty to our whole country, but especially to our children, to vote no. Those senators considering a yes vote should ask themselves, with the nation facing a possible bird flu outbreak, are they really prepared to roll the dice on the lives of their constituents by placing someone in charge of public health who has made it clear that he will prevent or she will prevent the approval of life-saving vaccines. And they should remember, in November, Americans voted for change, but they did not vote to bring back polio and measles and other deadly diseases. Throughout my career in building a company, in running New York City, in pursuing our philanthropic work, I've always led with a commitment to data and facts. I guess it's the Hopkins trained engineering in me. I believe in science, and for generations Americans did too, which produced innovations and breakthroughs that changed the world time and time again. But now too many Americans reject facts and seek their own. The burden is on us in this room to unite our nation behind an optimistic belief in the science of vaccines and future cures that will save countless lives. Ours is a mission of public health. It is noble, it is needed, and it is our job to bring everyone along. Of course, it ain't going to be easy, and there may be setbacks, but this group is critical to making progress on public health in the United States, and our team at Bloomberg will be here to support you, not only in the lab, but also in the halls of power. Let me close with one final thought. If there ever was an issue that both parties should strongly support, it's vaccines. After all, we might not even be a country were it not for vaccines. You'll love this story. Back in 1777, before even I was born, after the Continental Army had suffered a series of defeats, General George Washington feared that the war could be lost to smallpox, which was killing soldiers and harming recruitment. Incredibly, about 90% of the Army's casualties were due to infectious diseases, most of them from smallpox. British soldiers had been exposed to the disease in Europe, which gave them some immunity and a military advantage. So Washington took a bold and controversial step. He mandated that all soldiers be inoculated. And despite public fear and distrust of inoculation, the soldiers complied. And over the coming months, a mass inoculation effort took place across the Army. And as a result, rates of infection fell along with the threat of outbreaks, which saved lives and also led to a surge in new recruitment. Without that move, the war may well have been lost. And the greatest nation on earth would have, like so many children who lived before the age of vaccines, died in the cradle. So as we gather in this city, named for Washington, on the road that connects the White House and Congress, we want both ends of Pennsylvania Avenue and both parties to hear us when we say, it's a patriotic duty to leave politics out of vaccines, out of medicine, and out of scientific research. Thank you all for your leadership and for coming together today to find new ways to expand and celebrate your work. We have a great agenda ahead, and I'd like to turn the floor over to Josh Sharfstein and Michelle Spencer. Both Josh and Michelle have been great partners to our public health team at Bloomberg Philanthropies, led by Dr. Kelly Henning, who we also are very fortunate to have with us today. We're grateful for all the work they do, and I know the Bloomberg American Health Initiative is in good hands with their leadership. Josh and Michelle, would you come out on the stage?
Good morning. Thank you, Mayor Bloomberg, and welcome to all of you to the Bloomberg American Health Initiative Summit.
Now, in case you haven't figured this out already, this will be a Bloomberg American Health Summit like no other. Michelle, we're going to start with the game. You ready?
Ready.
The game is called Understatement or Overstatement. Okay. All right, we started with 8 fellows. Now we have 251 from 31 states, DC, and 1 territory.
How many say understatement?
That's right, it's an understatement. We actually have 388 fellows from 43 states, DC, and 2 territories. We're not forgetting the Mariana Islands.
That's right. Today. So my turn. We started with no faculty affiliated with the initiative, and now we have over 1,800.
Not quite.
That's right. We have 264 affiliated faculty.
The initiative has funded projects that have led to progress on addiction, violence, the food system, adolescent health, and the environment.
That's not an overstatement, nor is it an understatement. It's a fact. We'll hear more about the great work today of our faculty and our fellows.
So our theme for this year's summit is Advancing Public Health in Uncertain Political Times. Understatement. Have the times for public health ever been certain?
No, but we've made it through because what we stand for matters. What we push for works. And despite what you may read, public health does have the support of the public to advance health and well-being.
So just last week, faculty at the Johns Hopkins Bloomberg School of Public Health fielded a representative survey of all adults in the United States.
Here are just a few of the policies that have the support of more than 2/3 of adults. Making safe and nutritious food accessible to people with low income. Expanding access to treatment for drug addiction. Providing a legal way to temporarily remove guns from people who are behaving dangerously. And redesigning roads to be safer for people walking, biking, and driving.
Now, this survey also found that a few ideas were not at all popular, with 25% or less support permitting access to raw milk, removing pollution controls, and the idea that was tested with the lowest support measured, removing school vaccination requirements. I don't know if Mr. Bloomberg is still here, but just to point that out.
There's a lot more we can say about all of this. And today, we'll be featuring real conversations about public health in this moment.
Including where and how to seek common ground, and where and how to stand our ground.
Welcome to the 2024 Bloomberg American Health Summit. To kick things off, we'll have a conversation centered around bridging the divides in public health. Please join me in welcoming former U.S. Surgeon General and Director of Health Equity at Purdue University, Dr. Jerome Adams, in conversation with Pulitzer Prize-winning journalist and associate editor of The Washington Post, Jonathan Capehart.
All right, Dr. Adams, thank you very much for being here. So I'm a newsman, and so being a newsman, I cannot ignore the news that was made by Mike in his opening remarks and his very strong words about the nomination of Robert F. Kennedy Jr. to be Secretary of Health and Human Services, which just put on your former Surgeon General hat, your medical hat, your reaction to the nomination and to the words that Mayor Bloomberg had to say.
Well, thanks so much for having me here today. And I would say, number one, the mayor emphasized that our healthcare system is broken. We spend 2.5 times the OECD average on healthcare. We have terrible, terrible results by any metric. So the definition of insanity is doing the same thing and expecting a different result. I think we have to acknowledge that. You know, the Senate's job is to advise and consent. I think, as the mayor mentioned, there will be a lot of questions that an RFK or any other nominee has to answer if they hope to get confirmed. But for me, I choose to look at some of the opportunities. And the mayor mentioned the life expectancy differences between us and the UK. He mentioned chronic diseases. He mentioned drug overdoses. He mentioned guns. I certainly think that at least the things that RFK is talking about in those spaces are opportunities for us to work with the next administration, no matter who actually ends up being secretary. So yes, we need to improve our community so that we can lower chronic disease rates, more opportunities for exercise, more opportunities to eat nutritiously. RFK is in recovery. Who better to lower stigma and to talk about these issues in RFK. I think that's something that even if he's not confirmed, I hope he leans into. And we obviously know that RFK is not someone who's in favor of widespread availability of guns. So I think there's a lot of opportunity that I don't want us to miss.
Mm-hmm. So the title of this session is Bridging Divides in Public Health. What is the divide?
If only there were one.
Is it a political divide or is it something else?
Well,
or all of the above?
I think the political divide is the obvious one, and it's the one that we pay the most attention to. We've literally in this country taken every issue and turned it into Democrat versus Republican, abortion, guns, access to health care, drug policy. We take everything and we make it binary. And it's what separates us from many other countries. I do a lot of work with Switzerland and Ireland. Their constitution is based on our constitution. They literally both wrote their constitutions based on ours. So it's not a problem with our constitution, but they actually have multiple parties. They don't force everyone into these false binary framing scenarios. So I do think it's political, but it's also rural versus urban. You see that. You see a lot of rural America feels like they've been forgotten about. I'm in the Midwest. Someone asked me earlier, are you surprised Trump won? I'm from Maryland. I come out here all the time. You come out here and you'd be surprised he won. You drive anywhere through Illinois, Indiana, Ohio, it ain't no surprise he won. And those parts of the country feel forgotten about. So rural versus urban is a divide. So many other divides out there that I think we need to try to bridge. And I'll finish with this. I'll say there's more that we have in common than what there ever could be that separates us. And we have an entity in Washington, D.C., and in many cases the media that thrives on us focusing on our divisions and not what brings us together. I've lived in Berkeley, California, and they thought I was a Tea Partier there. And I live in Hamilton County, Indiana now, and they think I'm a socialist. I'm the same person, but guess what? I've had dinner, I've broken bread, I go to church, I go to school events with people in all of those communities, and I call them neighbors. I think that's what we need to focus on.
What role does misinformation play in the divide, especially when it comes from people in positions of high authority? Isn't this the challenge that we face today?
Misinformation is a grave challenge, and the current Surgeon General, Dr. Murthy, put out an advisory calling on us to recognize misinformation as a challenge. I'll actually flip to solutions. I think we need to do a better job of training all the people in this room how to communicate. I'm a doctor. If you ask me a medical question, I've been trained to give you a 45-slide PowerPoint presentation in answer to that question. I've not been trained to go on your show, Jonathan, and answer the question in a 2 to 3 minute oftentimes combative interview where I'm trying to get out my talking points.
Never on my show.
Well, you've never invited me on your show.
We can change that.
So that said, we need better communications training. We need to learn how to be on TikTok. We need to go on podcasts. Joe Rogan is going to continue to be the most trusted person on health for many folks out there if we don't know how to interact in his space. And so many of you follow me on Twitter. I get a lot of flack for being on Twitter. It's not professional of you, Dr. Adams. Well, most people, even healthcare providers, get most of their medical information online. So if we're not there, and the Joe Rogans of the world are, we're going to continue to lose. We need to figure out how to communicate in this space, and we need to learn how to speak to our target audience and not to each other in these echo chambers.
Dr. Adams, one more question on this. Then how should we respond to an elected official? I don't know why maybe if I sit like this and don't move, my mic won't go out. How should we respond to an elected official who is the person who is disseminating misinformation, disinformation?
Well, and again, it depends on who you are. The media has a role to individuals out there. Your job is to recognize that misinformation, which the Surgeon General helps us do, and to, if you don't agree with it, then to vote them out of office. That is how democracy works. But here's the challenge. Who's going to be the arbiter of what is and is not misinformation? And I'll give you a very concrete example because I don't want to talk in platitudes here. Joe Biden said that we had a pandemic of the unvaccinated. Was that misinformation? We subsequently found out that the vaccines aren't great at preventing infection. They're great at preventing severe disability and death, but they're not great at preventing infection. So was that misinformation? I don't know. It depends on who you ask. Joe Biden also said, and I talk about this in my book, that if he was president, he said, when you name me president, I will enact a federal mask mandate. He's leaving office in a few weeks. Has he enacted a federal mask mandate? Was that misinformation? And I don't say that to criticize Joe Biden by any means. I say that because it's really hard for us to determine, okay, this person is wrong, this person is right, and oftentimes what we saw in the pandemic is information changed and that information was politicized, and ultimately we lost trust. We lost trust because the people who were saying something was misinformation were subsequently shown to be wrong.
In the 4.5 minutes that we have left, and I'm not going to belabor this point, I'm just going to make this, I got to sit like this again.
See, the mic doesn't like you.
I know, clearly the mic doesn't like, oh, thank you. Just to be clear, there are several things you said about current President Biden, but let's just be clear. Former President Donald Trump said to people that they should ingest bleach. So it is...
Actually, no, he didn't. Please read my book. Again, this is misinformation right here. He did not say you should ingest bleach. Read my book because we don't have time to go into it, but people keep repeating that. Look it up. He did not say people should ingest bleach. We had a conversation at the White House down the street, led by scientists, talking about disinfectants that we could use to help combat COVID. And I talk in the book about how the president, and I will say this, he should not be opining about scientific issues while the scientists are standing next to him on stage. Please let the scientists and the doctors talk. But he never said ingest bleach. Look it up. Call me out on it.
I mean, okay.
So is that misinformation or not?
In the 3 minutes and 17 seconds that we have left, can you share examples of efforts you've been involved in to advance health in what may seem like surprising ways, working in a red state where you live now in Indiana? Let's just start with Indiana.
I appreciate the opportunity to talk about this because a lot of people, the mayor said a lot of things I agree with. He also left you all feeling terrified. And a lot of people are scared right now. But I want to tell you, with crisis and with turmoil sometimes comes opportunity. So I was Indiana State Health Commissioner under Mike Pence, who at the time was one of the most conservative governors in the United States. Mike Pence now is not even considered, I mean, Republicans call him a Democrat now, but at the time, he was one of the most conservative governors, and we were able to expand Medicaid in our state, one of the first red states to do it. We were able to expand syringe service programs in Scott County, Indiana, and we also, if you can throw the slide up there, were able to actually increase public health funding in our state by 1,500%. $250 million in our state. So I tell you that because there are opportunities if you learn how to communicate with your target audience. I'm going to give you all some cheat codes here on how to speak Republican. This is based on my experience. Number one, you really have to understand there's a value placed on individualism and choice. And so I often talk about we need to create opportunities for people to make healthy choices by building healthy communities. That's something I say that often resonates with Republicans. Another thing that Republicans really care about is the economy and the workforce. So I work with employers. I put out a report when I was Surgeon General of the United States that we made in concert with the U.S. Chamber of Commerce, talking about the impact on workforce and the economy. Transparency, I think we need to do a better job of making sure we have local data. Local data. Real statistics, 70% of people think they're above average drivers.
Oh, I know I am.
I'm going to let that sink in. And the point is that everybody thinks there's a problem. Nobody thinks the problem is in their community. So we need to leverage AI and data to give people real-time data. Again, I would say that if you do these things, if you make the workforce and economic case for health, then we've proven over and over again in Indiana that you actually can move forward public health initiatives.
In the 42 seconds we have left, how concerned should we be about H5N1?
I'm very concerned. And number one, I'm concerned because you're starting to see it jump into more and more animal reservoirs, so it could really get to a point where we have human-to-human transmission. And I talk about this all the time on Twitter, on my social media channel, but here's what I'm more concerned about. Again, teaching you all how to speak Republican. I'm not as concerned right now about human transmission. I'm concerned about the fact that 30% of the bird flocks in California have seen infections, that egg prices are going through the roof, that our food supply and our economy are going to be impacted if we don't really lean into bird flu. So we need the new administration to really have a strong pandemic response policy, because if not, then all their other priorities are going to get distracted from.
And with that, we're going to have to leave it there. Dr. Jerome Adams,
on your show.
20th.
Buy my book, Crisis and Chaos. It's on Amazon. I talk about all these issues in the book, including the bleach story.
20th Surgeon General of the United States. Thank you very much.
Please welcome Dr. Thomas Dobbs, former Health Commissioner, State of Mississippi, in conversation with Sheryl Gay Stolberg, Washington correspondent at the New York Times.
Well, hello, Dr. Dobbs.
Good morning.
Good morning. It seems our clock is already ticking. So, first, I want to address the elephant in the room. You are that Dobbs, the Dobbs of Dobbs versus Jackson Women's Health. I know that your name was on that case by no fault of your own, but through the by dint of your job. But I'm wondering, how has it been to have your name on this landmark health case?
It's been kind of a surreal experience, to be honest. It's not something that I had any interest in being involved with. Actually, I had strong interest to not be involved with it at all. Actually, the case was named after my predecessor, Dr. Currier, and it's just a quirk of me being the head of the regulatory agency that oversaw medical facilities. It's been pretty bad.
And if I'm not mistaken, she resigned. She stepped away, perhaps in order to have her name removed from that case? And I wonder why you didn't do that.
Well, I think she was, she had done a long tour duty, and that was a plus to sort of be removed from that. But no, and it's just one of those risks, right? It's kind of collateral damage. If you want to do good work in a red state where these sorts of challenges are, you have to take these sort of risks, and that's kind of how it played out.
So more to the point of bridging the political divide, you've worked in a very red state. You had said that early on there was kind of a unity about how to respond, but then the unanimity devolved over time. And in 2021, months before the Delta wave, Governor Tate Reeves eliminated the mask mandates throughout the state. And I wonder how you dealt with that.
The Delta wave was the worst by far, because it was, I think, mostly preventable. And if you look at states that were more thoughtful about preventing COVID transmission, you can see an entirely different wave of mortality and hospitalizations than we saw. Early in the pandemic, everybody was scared, and there was some more unanimity. And we fought together, and we crushed the first wave in the spring of 2020 in Mississippi. But after that, there was a lot of return to normal sort of thought processes. Fortunately for me, and I wasn't an appointee of the governor, I actually had a board of health, so I had some autonomy. And I think the governor actually kind of liked it that way. He could sort of disavow himself of my actions, which was fantastic, and he allowed us to disagree. And so while he refused to do anything, I respected his role, and I respected his authority, which obviously as the elected leader of the state, he has. But then we were able to work sort of behind the scenes with communities that were sort of like more willing partners. Mayors specifically were great targets to sort of work with, and we did have some small areas of success, finding various lanes of opportunity where we could prevent death and morbidity where we could.
Yeah, so Mississippi also has a very diverse population. 40%, nearly 40% African American. It's also, as I said, a very conservative state. And I'm wondering, in thinking about vaccine hesitancy in those two populations, what did you do that worked and what didn't work?
It's such a great question. I can tell you where it worked really well. And kind of coincidentally, Dr. Adams and I met right before COVID, and he was meeting with actually our director of chronic disease prevention, Dr. Victor Sutton, who was well connected with a lot of the communities at risk. Before this, because of chronic disease and other stuff, barbershop initiatives, faith initiatives. And then when COVID hit, we recognized immediately that there were going to be massive health disparities. And so one of the things that we did that I think was kind of innovative, if you're familiar with the incident command structure, which is sort of like the disaster response thing, we actually elevated Dr. Sutton to a command level post, consistent with like logistics and everything, for health equity. So every decision involved him involved in sort of the operation. And so that was very successful because he had pre-existing relationships with people in the community. We were able to find out what folks needed. And part of it was asking the questions to understand what people's perceptions were. What we found out pretty quickly is there was a theory, or basically a thought process, that in certain parts of the community there was mistrust, especially in the black community around Tuskegee and all that kind of stuff, which is legit. But when we really asked the question and did sort of broad surveys, what we identified as a bigger barrier was not engaging people where they lived. Instead of having these sort of massive drive-through clinics, folks didn't feel comfortable doing that. They wanted to have small local drive-throughs. And through totally shifting our paradigm, we were able to sort of massively improve our vaccination rate in those parts of the population.
But I want to jump in and ask you about the conservatives, because I suspect that was a lot harder. How did you do there, and what did you do there?
So interestingly, with the faith community, it was an utter failure.
Why?
Well, when I would talk to the ministers, especially in the evangelical side of the ledger, they said, my congregation will flay me alive if I go forth advocating for vaccines, because it had become such a hard political thing. Now, what we found, there was different targets we could do on the more conservative side. Mayors were pretty good, and even within these conservative congregations, there were, especially older people, who were bearing the brunt of the mortality, were really open to vaccination and prevention. So trying to find our areas to sort of squeeze in there a little bit, but there really was sort of crazy opposition, and one of my good biking buddies was a Baptist preacher, and he gave me a lot of insights, which is fascinating.
So I'm curious, Dr. Adams mentioned his book. I don't want to be self-promotional. I actually am working on a book about politics and public health that explores some of these themes, including why conservatives, and particular Christian conservatives, have seen a declining faith and trust in public health. And I just wonder, why do you think? Why has that happened?
It's probably not as old as we think, and I don't know if part of it's an engagement piece in having these sort of relationships, but reading about the yellow fever outbreak in the 1800s, there were a lot of similar themes, and so it's kind of a recurrent theme of this conflict between individual rights and public safety, and we see that over and over again, and in the South and the red states, it's a lot more profound.
Yeah. We have 1 minute and 30 seconds left. I want to ask you about vaccination in Mississippi. Mississippi was long the state that had the highest vaccination rates in the nation, childhood vaccination rates, and the tightest rules. But last year, I wrote about this, a court ruling eliminated or reinstated rather, the religious exemption. And I'm wondering, are you worried that more and more parents are opting out and a vaccination, and what do you foresee?
I am very worried about it. I do think we're going to see some outbreaks. Years ago, like 1990s, we used to have ICUs regularly filled with kids with meningitis from Hib, H-flu influenza, and that's gone, right? We feel like these are things in the remote past, but they're not the remote past. They're going to be back on us again. Now, we'll have to find other avenues to be successful. Our physician community, our pediatricians are very strong advocates. We'll have to continue to work with them as trusted communicators with parents. What worries me more than the religious exemption, because we haven't seen as much of that uptake as we thought there would be, is this sort of pervasive misinformation. It's insidious, it's dangerous, it's troublesome to see that people enjoy believing lies, and this is what worries me.
10 seconds, 7 seconds to go. What's your advice to state public health officials operating in a very polarized climate?
Find your role, right, and honor it. Engage with the political leadership so that they make the hard decisions, and listen to people and hear what they want, and don't make assumptions, because we made some bad assumptions.
Okay, thank you so much.
Thank you.
Let's give a round to Dr. Dobbs.
Thank you
so much. It's good to see you. And it's my pleasure now to welcome Dr. Francis Collins, former director of the National Institutes of Health, former head of the Human Genome Research Project, and esteemed geneticist. Hi, Dr. Collins. Good to see you. All right, well, we began with the elephant in the room for Dr. Dobbs, and now I'm going to give you your elephant in the room. I know you're a federal employee. Yes. We don't want to get you fired, but we did just hear Mayor Bloomberg say that it would be beyond dangerous to have Robert F. Kennedy Jr. as health secretary. And I know you can't comment on that. I'm not going to make you say no comment, but I do want to know what you took away from your experience in the first Trump administration in a very polarized climate. How did you navigate those waters?
So you are correct. I am running a research lab at the National Institutes of Health working on diabetes and a rare form of aging called progeria. So I am a federal employee, so I'm not going to be able to comment on any particular nominations.
I told you.
But I will say, in the first Trump administration, I was a big part of Operation Warp Speed. That was an amazing achievement that by pulling together the public and the private sectors. And I got to say, a big shout out to Secretary Alex Azar, who was a big part of the way in which that all came together. And in 11 months, we produced this mRNA vaccine that had unprecedented safety and efficacy compared to anything that most of us dared to hope for. So it was a remarkable success of how the government can really work effectively in that situation. And it was all based upon the rule of evidence, that nothing was going to happen, nothing was going to get approved unless there was really rigorous data to show that it was working.
But then once it was approved, that's when the trouble began. How did you had trouble selling it, if you will?
Yeah, and I think there were a number of missteps that happened along the way. People like me who were in the position of being able to try to explain to the public what was happening with COVID were often in a circumstance where we were dealing with incomplete data, and then things changed and you had to change the recommendation, and people began to wonder, wait a minute, why is this happening? Do those people really know what they're talking about? I wish we had been more consistent in saying, this is an evolving situation. We're going to tell you the best information we've got right now, but we might have to change it later when more information comes along. But yes, people did begin to wonder whether all of this information was true. And then we had social media with a massive amount of really troublesome misinformation, some of it intentional disinformation, that caused people to begin to doubt whether the vaccines really were safe and effective. And the saddest statistic of all of this, and this is Kaiser Family Foundation's analysis, is that between June of 21 and March of 22, on the basis of misinformation that caused people to decide not to trust the vaccines, 234,000 Americans died.
Wow.
That's like 3 jumbo jets crashing every day for 9 months.
So
that happened because of misinformation.
I'm going to jump in there because our time is short. And I know that one area where you have found common ground is in promoting a move to eliminate hepatitis C. You've written that you watched your brother-in-law die of the disease, that 2 years later, medical science invented a cure, a simple pill, but it's expensive and people don't have access. And so you are now on the verge, I think, of passing bipartisan legislation.
I hope so.
And you have written that it's both a compassionate plan to expand access, but also deficit reduction. And I am wondering, how do you promote compassionate plans, public health initiatives, and rally bipartisan support when they're not deficit reduction?
That's a lot harder. And I think anybody working in public health recognizes that we do have fiscal problems in our country with deficits that have ballooned into a very large space. But I'm glad you brought up hepatitis C, because everybody, this is a really good story. This is good news. Here's a disease that currently affects 4 million Americans, and it is curable. 1 pill a day, 12 weeks, 95% cure rate, no side effects. But most of those people don't have access because of cost, because of our healthcare system that is not equitable and doesn't reach marginalized communities. You get hepatitis C from contaminated blood. A lot of these are folks who have had an experience with intravenous drug use, maybe doing fine now, but they're infected. And over the course of 20, 25 years, they're going to end up with liver failure. They might need a liver transplant, which costs $1 gazillion. They might get liver cancer. The Congressional Budget Office, just recently looking at the legislation which has been put together by Senators Cassidy and Van Hollen, notice bipartisan, has indicated this will be cost-saving in 10 years if we just introduce it. And I am hopeful that in the course of the next 2.5, 3 weeks, that the momentum behind this will be sufficient that we will be able to get this into the end zone and launch this project next year.
The forever hope for the lame duck congressional session.
Come on.
So I talked to Dr. Dobbs about evangelical Christians.
Yes.
And you are an evangelical Christian. You've written a whole book about it.
Yes.
I am wondering, what do you think accounts for the loss of trust on the political right and within the Christian community, and what can be done about it?
Well, let's say that it's clear to everybody now that we have an extremely divided society, and that affects people of faith as well as people of no faith. And it didn't just happen overnight. It's been building over the course of 20 or 30 years. And COVID came along at a point where I kind of thought at first, maybe that's going to bring us together. Isn't that what a common enemy is supposed to do? And for maybe the first 3 or 4 months, we were kind of unified, and then we started to not be unified. And now it seems that this drove us even further apart. And people of faith who have had a history of not always being completely comfortable about scientific claims, thinking maybe scientists are all atheists, believe me, we are not, had, I think, an increasingly high level of skepticism about what they were hearing. And frankly, politics, which got into this in a big way, also has gotten into the church in a big way. And a lot of people sitting in the pew on Sunday morning are wondering, hey, what happened to us? Why aren't we talking about loving your neighbor and even loving your enemy instead of all of the animosity that seems to have found its way in there? So people of faith were whipsawed by all of this. Good, honorable people who want to do the right thing. And many of them sort of were influenced by the messages they heard and were a little less likely to think the scientific facts were trustworthy. And here we are.
So, and you, in a very personal way, have tried to bridge the divide with your work through a group called Braver Angels.
Yes.
It's a nonprofit working to kind of depolarize America. I know you were teamed up with Wilk Wilkinson,
yes,
a trucking manager, and I want to ask you about something you said to him last year that actually has rankled a lot of people in public health. You said that public health people during the pandemic had, quote, made a, quote, really unfortunate mistake by not paying enough attention to the social and economic consequences of the people whose lives you were trying to save. And you said, quote, if you're a public health person, you have this very narrow view of what the right decision is. And that is something that will save a life. Doesn't matter what else happens. And I'm wondering, do you stand by those words? And given that, what advice do you have for your successors?
So, appropriate question. Braver Angels has been a wonderful opportunity to put together people on the red and the blue sides.
You have 17 seconds.
That quote is taken a little out of context. I was being quizzed about how, as part of the COVID response team, I would make decisions. And I said, I took the Hippocratic Oath. For me, saving the life is number one. Other parts of the decision-making process could worry about the economy, and they should, and worry about the schools. But for me, it's how I'm going to keep people from dying, and I'll defend that. But I grant you that that mix of perspectives was not always fully represented, and there were circumstances where schools were closed for too long and businesses were closed for too long. A lot of this we can learn from. But I will say, I think when you look at it, public health, for the most part during COVID, did everything right that they could with the evidence that they had, and those are good, honorable, wonderful people, including a lot of people at NIH, and it is really sad to see them now being scapegoated as they are in some circumstances.
All right, we will have to leave it there. Thank you so much, Dr. Collins.
Thank you, Sheryl.
I'll let you go. And then
Please welcome Ronald J. Daniels, President of Johns Hopkins University.
Good morning. Well, there's no denying for those of us who inhabit institutions that are proudly based on foundational commitments to things like the power of data, of science, of expertise, the current moment is, dare I say, fraught. We, not without justification, feel caught in a set of tectonic societal shifts that have cast doubt on the legitimacy of our core enterprise. And while we certainly can't succumb to the belief that we are entirely without any responsibility for some aspects of our current moment, the criticisms leveled against us lack nuance. They are disproportionate, and they are irresponsible. And I truly fear, that they will lead to consequences that will inflict grave costs on our country's vaunted strengths in evidence-based research and public health practice. How's that for a really inspiring talk to a room full of optimistic practitioners of public health? But bear with me. This does, in fact, get better. Because what, for me, is fortifying in this moment and bears, I think, repeating at this convening is that this initiative is even more poignant today than it was 8 years ago when it was first established by Mike Bloomberg. At that time, as he mentioned earlier, Mike was alarmed by the growing evidence that life expectancy was declining both in relative and in absolute terms in the world's most prosperous country. More than that, these global trends mask deep and wrenching disparities in life expectancy between those with and without college education, a set of disparities that knows no geographic bounds and has grown only more politically salient over the years. A set of disparities which has had such a profound and destructive impact on our nation's politics and our cohesion. And so the focus that you have all trained on the major contributors to those corrosive and persistent disparities, addiction, gun violence, food insecurity and obesity, adolescent health and environmental degradation, remains relevant and urgent. If the core public health priorities embraced by the Bloomberg American Health Initiative continue to be pertinent, so too is the way in which the program has systematically drawn upon lived experience and battle-tested perspectives of public health practitioners who hail from communities across the country. We know and we acknowledge that science alone doesn't always, if ever, dictate a straight line to a single policy intervention. Choice, discretion, and judgment, informed by local knowledge, felt need, and existing institutional arrangements, local culture, are all required in determining how best to respond to a concrete public health challenge. And it's through the steadily growing network of the graduates of the Bloomberg American Health Initiative program, all the fellows who are here, these folks who have mastered the science and the art of public health practice and policymaking, that we're able to interrogate what works and doesn't work and refine our interventions accordingly. And despite the rancorous acrimony that has truly deformed our national politics, the quiet, the focused, broad-based work of our graduates taking place in literally hundreds of local communities across our country shows the promise of public health to develop humane and innovative solutions to address felt need and improve the human condition. Public health is not now and never has been a flyover work. It is instead the work of and with the community, whether introducing low-cost test strips to stem the surge of fentanyl, equipping state leaders with data-driven practices to halt the tide of climate crisis, or expanding access to healthier food options in communities long denied basic sustenance. And so, while I acknowledge the seriousness of our moment, we cannot lose sight of how right and important the work that you do is, the impact that it has, and the optimism that it imparts. I don't want to be naive and suggest that there's no peril from the decisions that are being made today and will be made in the months to come, including about how and whether science, expertise, and data will continue to fuel this country's dazzling success. But what won't change is the fact that the project we dedicated ourselves to nearly a decade ago continues to be right and relevant to our times, and I think will help provide a guiding light that shows us a path forward. Your work is really, really consequential. It is inspiring. We're so enormously proud of you and the work that you're doing. So thank you for doubling and redoubling your commitment to this important work, to this important enterprise. With that said, it's my great pleasure to introduce our next speaker. A devoted public servant, Xavier Becerra understands the powerful intersection of law, policy, and public health from his early days as a legal advocate for people with mental illness. Secretary Becerra has spent his career ensuring all Americans can access affordable, high-quality health care. As California's Attorney General and 12-term congressperson, he championed the Affordable Care Act, fought for greater patient safety, expanded access to Medicare and Medicaid, and established key safeguards to ensure the health of frontline workers during the pandemic. Today, he is the 25th Secretary of Health and Human Services and holds the distinction of being the first Latino to occupy that office in the history of our nation. Please join me in welcoming to the stage Secretary Xavier Becerra. Thank you.
President Daniels, to you, to Mike Bloomberg, and certainly to the folks who helped put together this public healthcare initiative, thank you very much for the invitation. But real thanks goes out to those of you who were out there. If you were at all involved over these last 4+ years in the effort to save lives, whether you were the researcher who helped us develop the life-saving treatments, whether you were the network organizer who made sure we reached people in places that often are left behind, or whether you are the people who continue to run our public health network, thank you for what you have done. You did, and you are saving lives. I mean, literally, you are saving lives. If there are any folks here from community health centers, the federally qualified community health centers, you saved lives. If you work in a pharmacy, you saved lives. If you worked on the vaccines that saved millions of people, you know you saved lives. And so to each and every one of you, thank you. And to those of you who are students who are hoping to get to save lives, science doesn't change. Politics might, but science doesn't. And so my sense is you will go forward with that tried and true process that we use in science for health, which is your North Star is evidence. Evidence based on research and evidence based on practice, not on politics. And so I say to you, don't stop. Keep going. Be as intentional today as you were when you decided to go into this field. And you will make a difference and you will save lives. So today in America, there are more Americans who have a chance to go to a doctor or to visit a hospital and leave their child there and not worry about going bankrupt. More people in America today can do that than ever in the history of the United States. More than 300 million Americans today have their own health insurance, whether it's private or whether it's public, but they have their own health insurance, which means they can walk into a doctor's office without bowing their head. They can leave their child in that hospital without worrying whether they'll be able to pay the mortgage or the rent because they come with coverage. That has never happened in this country before. Today in America, we are inventing the next generation of medicines and vaccines that will continue to save lives. Today in America, we're developing some of the best ways to move our country's health system from one that treats illness to one that promotes wellness. But I could tell you a different story if you want to go back with me. Just let me take you back a few years. Because today, if it were 4 years ago, would have been COVID ravishing our country. Americans losing their jobs. Americans losing their health care. Many of you may have been among those. The day President Biden took office, January 21st, 2021, we got hit. We got hit by 9/11 3 times on one day. That was the severity of the crisis of COVID, that more than 4,000 Americans perished the day President Biden took the reins from the previous administration. That was where we were some 4 years ago. And it's so easy today, when none of you are having to wear masks, when none of us are worrying about socializing together, that was where we were. And our path was getting worse because the plane was descending rapidly, out of control. And so it is fascinating to see where we are and to remember where we were. But remember that we are where we are today because of the work that you all did, which was based, as I said, on that research, on that practice, not on the politics. And so today we have an opportunity. We should treat today the way we treated 4 years ago, at least under President Biden's watch, a break glass moment when it was time to do things differently. And the result was we offered to Americans a life-saving treatment, a vaccine that became available to everyone, not some of us, not based on your income, not based on your zip code, not based on your status, every one of us. And the result was we moved forward. The result was everyone had a chance to get a vaccine. 270 million shots in arms to date have gone. But the bigger and more important element of that fact is that not a one of you had to pay a single penny to get that vaccine. That's what breaking glass means. That's what it means to move forward. That's what it means to not let disparities in America get in the way of getting a shot in the arm of everyone, whether you're black, brown, white, Asian, Native American. You can do that kind of stuff. And so what I think it's important to understand is we are at a fork in the road, and we have to decide where we go. And let me tell you how I think we get there the best way possible. Once you break the glass, be intentional. It was not luck that under President Biden's watch, 270 million vaccines have gone into the arms of Americans. It was not coincidence that today there are more Americans who have health insurance coverage than ever before. And it is not easy to get those types of historic numbers into the records of America. It is intentional. And we must all make sure we are intentional as we move forward. To make sure we can move forward with everyone with us, because there aren't a lot of folks with us today, whether it's on vaccination, whether it's on the need for a more national public health system, because we don't have a national public health system. We have a nationwide system of public health based on 50 different states doing it their own way. But if we do this intentionally, we can have results that take us from 4,000 Americans losing their lives in one day to being able to say that we are moving forward together. And so I will close by mentioning what I learned very well by one of the greatest minds I've ever seen, my daughter's piano teacher. Carl Mathis, a wonderful pianist, used to tell my daughters, please make sure you go home and you practice your pieces. Now, when you practice your pieces, practice them right. Because practice doesn't make perfect. Practice makes permanent. How you practice will determine how you play. We need to practice right when it comes to healthcare. We need to make sure our research is founded on science and evidence. And we need to make sure our practice is guided by that evidence. And we keep that North Star. If we do that, we will once again pull out of any crisis that we face. We will once again change those statistics. We will once again prove that we are ready to lead. But if we do that, it will be because you, the researchers, the healthcare advocates, the healthcare professionals, are the ones that remember your North Star and never let politics get in your way. I have been thrilled for 4 years to have a chance to watch some real professionals do their work in healthcare, and we have made a difference. But it was not an accident. It was not coincidental. It was totally intentional. Let's be intentional. We'll get some things done. Thank you very much.
Please welcome back Dr. Joshua M. Sharfstein, Director of Bloomberg American Health Initiative, and Michelle Spencer, Deputy Director of Bloomberg American Health Initiative.
Thank you. Thank you so much, Secretary Becerra.
Yes, I hope you all are having a good time. Yes? Awesome. Okay, Josh, now I have a game.
I'm
Yeah?
excited.
You're
I'm
excited?
excited. I'm good at games.
Okay.
I want to win.
You want, this is called Which Branch of Government Am I?
Okay.
Are you ready?
I'm ready.
Okay. Again, which branch of government am I? I have a major impact on policy,
Legislative.
but I do not pass laws,
Executive.
and I do not administer laws either.
Judicial.
Excellent, excellent, excellent. The courts have an enormous and often unappreciated impact on policy. At the Bloomberg American Health Initiative, we are developing a public health tool to do just that, to shed a light on the health impacts of judicial decisions. We should take a look. Yeah?
Court decisions can profoundly affect the well-being and safety of our communities, even those cases that don't directly address health and healthcare. So how do we make these court decisions result in actions that improve health, promote equity, and save lives? With judicial health notes.
Until now, there wasn't an evidence-based process to assess the potential health and equity impacts of legal decisions. We created judicial health notes to fill that gap.
They systematically analyze court decisions across a broad spectrum of issues, including the environment, public encampments, and gun ownership. These notes suggest how to maximize health benefits and minimize harms.
Each note draws from peer-reviewed evidence and demographic data to accomplish one goal: elevate health and equity considerations when legal decisions are being implemented.
At the core, we tried to answer 3 questions. 1, why does this decision matter? 2, what are the potential health effects and who is most likely to be affected? 3, how can this analysis be used to protect public health?
By answering those questions and exploring the potential impacts of these decisions, we can truly advance health equity.
From state courts to lower courts to the Supreme Court, judicial health notes can help policymakers, advocates, and community leaders understand decisions with newfound clarity. Together, we can bring public health to the forefront of legal decisions.
Hello everyone, I'm Madlen Davies, a senior editor at The Examination, which is a new non-profit newsroom that investigates health threats from corporate activity. So we look at tobacco, industrialized food, oil and gas, and the drug industry. And I'm absolutely delighted to welcome Professor Keshia Pollack-Porter, the Bloomberg Centennial Chair at the Department of Health Policy and Management, Johns Hopkins Bloomberg School of Public Health. As you've seen in the video, Professor Keshia Pollack-Porter is going to share details on the Judicial Health Notes project for the very first time today. It's just launched, it's hot off the press, as us journalists like to say. So Professor Pollack-Porter, could you tell us what problem you're trying to fix here?
Yeah, first of all, thanks, Madlen. We are thrilled to release the Judicial Health Notes today. And the problem we are trying to solve is that every single day, decisions are made in sectors outside of health, such as transportation, energy, housing, and health impacts aren't always at the forefront. So my colleague Stephanie Kerrigan and I and some other colleagues created a tool a few years ago called a legislative health note to focus on proposed bills. And we saw an opportunity to also highlight court decisions. And so that's the problem we're trying to solve.
And could you talk me through one key example of a judicial health note?
Yeah, so today we released 3 health notes that we've been working on for the last several months, and one of them relates to a case that some of you may have heard about, and it's called Grants Pass v. Johnson. And so this is the case that the Supreme Court, the US Supreme Court this summer, basically ruled that it is permissible to remove homeless individuals from encampments even when there's no place for them to go. And so basically what we did is we saw that the discourse around this case didn't involve public health or equity in a way that we thought needed to happen. So we conducted an analysis, we pulled together data, and we pulled together some literature, and we showed the impacts for individuals who are forcefully moved. We saw how their access to treatment and healthcare could be disrupted. We also saw that there were challenges for individuals where actually instead of reducing or making it safer, it actually increased interactions with law enforcement. And we saw impacts on people actually having fines or more interactions with police that could actually make it harder to get homes in the future or secure a job.
And what impact are you hoping these judicial health notes will have?
We hope that we will be able to highlight the potential health impacts, particularly when health is not always at the table. And I want to acknowledge all of my colleagues, including myself, who oftentimes submit amicus briefs to highlight the potential health impacts and try to influence a judge's decision. But what we want to do is say, well, after a decision is made by a judge and somebody has to do something to comply with the law, during implementation, how do we think about health and equity? And that's our focus. So what I hope and my vision is that people are calling us, that they want technical assistance, and that they're looking at how to use this tool to bring health to the table when health is not being focused on.
And did it shock you that judges weren't taking public health considerations into these decisions?
Not at all, not at all. And I think everybody's laughing here. I mean, I'm sure you're not surprised as well. You know, so much of this work is part of what we've been moving forward, which is called Health in All Policies, and really thinking through how can we be intentional about bringing health to the table in a number of decisions. And so we weren't surprised, and that's why we created this tool, and we believe there's great potential to highlight how we can bring health to the table when health is not being discussed in a way that we think is grounded in evidence and doesn't take into account all of the things we know about how to improve health and to reduce harms.
And I found this incredibly inspiring when I learned about it. Could you talk me through some other examples of judicial health notes? I think the audience would be really interested in hearing about them.
Yeah, we looked at another case that relates to the environmental challenges focus area of the Bloomberg American Health Initiative. And this one relates to a case out in Utah where basically there's a big lake that's drying up. And you might think, well, of course there are health impacts there, but this particular case, when you looked at the court decision, and it's actually the courts are in the process, the judges in the process of deciding this decision, we wanted to highlight all of the ways that the drying of this lake could impact health. And so we pulled together the evidence, and we saw impacts on respiratory illnesses. We saw equity impacts in terms of the people who live close to this area. We saw potential for toxins to be carried from the dry beds in the land, and this really was important. And we hope that individuals and advocates and other organizations will take our findings and help to really think through how we can reverse some of these impacts, how we have the evidence to say, let's look and see how we can actually slow down the degradation of this water source that's so critical for Utah.
Mm-hmm. And we've got 30 seconds left. I think we've got a QR code to bring up. Professor Pollack-Porter, what's the vision for the project going forward?
Well, first of all, take out your phones, scan the QR code, and we hope, my colleague Stephanie and I and our whole team at the Johns Hopkins Bloomberg School of Public Health, hope people reach out, contact us to learn more about the judicial health notes, check out the ones that we have posted online, and please contact us and promote health in all policies through this new tool.
Thank you so much. So inspiring and exciting.
Thank you. Thank you so much. Thank you.
Please welcome Dr. Marion Nestle, Paulette Goddard Professor of Nutrition, Food Studies, and Public Health Emerita, New York University.
Hello. I'm really, really happy to be here. And I'll be even happier if my slides work, and they do. I write books about food politics, and all I can say is this is an incredible time to be writing about food politics. Here is the President-elect of the United States talking about the industrial food complex. The mind boggles. You can't make this stuff up. This was his tweeted announcement of Robert Kennedy as nominating him to be Secretary of Health and Human Services. We've already heard a lot about that this morning. And here is Robert Kennedy on the flip side of what he's talking about the food system. End chronic disease, go wild on food, get ultra-processed foods out of schools, get rid of artificial colors in cereals, get rid of chemical pollutants, get rid of mercury in fish, get rid of fast food, and do a few other things, end conflicts of interest in government. These are things I've been talking about for decades. You cannot make this stuff up. These are all food system issues, and by food systems, I mean everything that happens to a food from the time it's produced, distributed, sold, bought, cooked, and wasted. Everything that happens to it. You cannot understand why people eat the way they do, why we eat the way we do, without understanding the food production system as well. And food systems thinking is a really interesting and important way of looking at food. The global food public health, the major public health nutrition problems in the world today are problems that are related to food system, hunger and food insecurity, obesity and non-communicable diseases, the environmental effects of the way we produce and consume food, and now we're still dealing with the effects of the COVID-19 pandemic. All of these are related to dysfunctional food systems, and these are among the most important problems in society. We saw this during the COVID pandemic because the obesity was one of the factors that raised the risk for bad outcome of COVID-19, as did chronic diseases that are also related to diet. And all of these are underlaid by social determinants of health, where people live, how much money we have, how much education we have, and what I'm most interested in, the kinds of foods that we're eating. Microphone. And our food system is based on the people who are paid the lowest amount of money in our society. If you want to look at the lowest wage jobs in the society, they're food jobs. They're farm workers, they're fishermen, they're people who work in meat packing plants, in agricultural production facilities, in restaurants. And so our food system depends on low-wage work, and the politics of that are also mind-boggling these days. I keep talking about food as being political. I know that comes as a great surprise to a lot of people because food is personal. It's about taste and culture and what you believe and your feelings of identity and what your family eats and what you love to eat. But it's also political because it has a great deal to do with social status, with wealth and power and government, and who is making the decisions about what people eat. And I thought the politics of food were beautifully explained in one slide by the celebrity chef, Jose Andres, an extraordinary person who pointed out in one a tweet, I don't know, all of this stuff gets done on Twitter these days, that during the pandemic, that farmers were destroying potatoes. They were throwing away food at a time when people were lined up in cars for miles to get handouts for food banks. So the irony of the dysfunctional food system should not be lost on anyone. And I'm interested in nutrition, and it's a source of great sadness to me that people are enormously confused about what they're supposed to eat, when dietary advice is so simple that the journalist Michael Pollan can do it in 7 words. Eat food, not too much, mostly plants. And really, that's all there is to it. Beyond that, everything else is nutrifluff. It's frills. This is all that matters. The problem is that if you eat this way, it's very, very bad for business. And that's another great irony of the food system, is if we were all going to eat healthfully, the food companies that make the thousands and thousands of products that we love to eat in supermarkets would not do as well as they're doing, and that would be bad for the economy and certainly their economy. So what do we do about that? I think we have to advocate. We have to get involved in politics. Advocacy is a political process to change society, and what we need to be doing is advocating to improve the food system. If we're going to do that, we have to be advocating to end hunger, to reduce chronic disease, and to protect and improve the environment. And I know that that's what all of you are doing every day, and that's what makes me so proud to be here. There are rules about how to advocate. These are 3 examples of books that I think should be on the shelf of everyone who is doing food advocacy, particularly Organizing for Social Change, which is a manual for how to do it, and Bite Back, which gives examples of successful food advocacy. And what to do? I think you do a personal agenda. If on an individual level, you vote with your fork. You educate about food, not food products. You promote local and sustainable agriculture. You grow food, or you teach people to do that. You cook at home. You teach kids to cook and garden, and you do what you can to produce food waste. But if you want to be serious about advocacy, you also have to get involved in politics. And here's my food systems agenda, which I have in front of a rainbow because I know how ridiculous this is going to sound. You reform campaign funding and get money out of politics. You refocus agricultural production on food, not fuel, or fuel for automobiles or feed for animals. We should have a universal basic income so everybody can afford to buy food, universal school meals so kids can eat. We want a huge campaign to reduce obesity and chronic disease because that's what's killing us. And in order to do that, we have to regulate the food industry. If we don't have these goals, they'll never be achieved. So even though this seems like an uphill fight, it's worth doing. We got to do it. And I want to close with something from Michael Moore, the filmmaker, who said in these difficult times, he suggests that you practice kindness, read books, get real news, take care of yourself, stand for something, join something, and advocate for those in need. I know that that's what you're doing. Keep doing it. It's totally worth it. And I thank you very, very much for the opportunity to talk to you today. Thank you. Thank you. Where do I go? I go that way? I go that way.
Please welcome Congresswoman Lucy McBath, U.S. House of Representatives, Georgia's 7th District.
Well, good morning, everyone. And it is truly a blessing and an honor to be with you here this morning. What an amazing program that we have and you're able to witness, and I'm so glad to join you. Thank you to the Bloomberg School for gathering scholars and thought leaders here and inspiring the next phases of change. Mayor Bloomberg has proved to the country that when we see an issue and we come together for a cause, all worthy causes, we can bring about change and we can save lives. The reason that I do this work, like so many of you in this room, I'm sure is because it's personal to you, as it is personal to me. For years, I raised my son and watched him grow up in my home state of Georgia. I watched him thrive in a neighborhood full of kind and loving families. Jordan played with neighbors until dusk in our front yard, and we often visited with friends for weekend activities and Sunday dinners. And like many parents across America, I believed the schools and communities our family lived in created a safe and a secure place to raise a child. And I watched as Jordan grew into a caring and compassionate young man who was truly dedicated to making the community around him a better place to live. But on Black Friday in 2012, Jordan was sitting in the back seat of a car with 3 of his friends as they stopped at a gas station convenience store for some chewing gum before driving to the next mall to go shopping. A man parked next to them and complained about the loud music that they were playing in their car. He called the boys gangbangers and thugs, telling them to turn down that thug music because he couldn't hear himself think. Within 3.5 minutes, the man grabbed his gun, took a shooter's stance, firing 10 shots into their car. 3 of those bullets killing my son, Jordan, instantly. And this man claimed that he was standing his ground. And Jordan was only 17 years old. The phone call that I received that evening from Jordan's father telling me the fate of our son shattered me. It shattered my entire world. For a year or so, I was overwhelmed with grief. And I don't know how many of you here are people of faith, but for me, it was truly my faith that kept me from succumbing to that darkness. My faith and my love for my son helped me to use my pain to seek justice for Jordan, to help other families like mine grapple with their new normal, a life forever burdened by the ache of a loss of a loved one cut down by unnecessary gun violence. But I refuse to let that grief consume me. I was unwilling to let this tragedy be the end of Jordan's legacy. I worked hard to turn my pain into progress. And by doing so, I was asked to help other victims as the spokesperson for Every Town for Gun Safety and Moms Demand Action for Gun Sense in America. I traveled this country to testify before state legislatures, but also speak with survivors in the immediate aftermath of their tragedy, when they were mourning from their loss and reeling from the devastating truth that this country's gun laws had let them down. Of course, I couldn't have been given this voice and impact without the encouragement and the network set up by this incredible organization and leaders like Shannon Watts, John Feinblatt, and of course, Mayor Bloomberg. Every Town for Gun Safety gave me an opportunity to sound the clarion call for gun safety, taught me how to be an advocate, and provided me the space to fight for others. The nationwide calls for gun safety we now see have been strengthened on all sides with Mayor Bloomberg at the helm of a movement to demand that we can do better. We have to do better. We must do better. And so come 2018, I ran for Congress on gun sense policies in a district that was once held by Republican Speaker Newt Gingrich. And it may come to no surprise to you that many people tried to steer me away from this path. They told me that a black woman couldn't win in Georgia running on a campaign for gun safety. Well, they were wrong. We knew that. This organization knew that. We could win on this message everywhere. I won in ruby red Georgia because everyone wants their kids to be safe. No parent, grandparent, aunt, or uncle wants a child they love to hide under a desk during a lockdown drill when they should be learning about reading and writing and arithmetic. I am proud to say that in the 6 years since I have been sworn into Congress to represent the grand state of Georgia, that we've seen historic progress. We passed the first comprehensive gun safety legislation package in more than 30 years. We passed that into law, which included parts of my extreme risk protection order legislation to empower law enforcement and loved ones to act if a person is in crisis and they have access to guns. I helped to secure $500 million in community violence intervention funding for organizations that are doing the important foundational gun violence prevention work every single day in their communities. And the Biden-Harris administration created the first ever White House Office of Gun Violence Prevention. Currently, I lead 2 pieces of legislation to regulate the most lethal weapons, the assault weapons ban and the Go Safe Act, both vitally important steps forward in our work to keep weapons of war out of the hands of people who should not have them. Through the work of this historic bipartisan measures that we have taken in Congress, these actions taken by this administration and the advocacy and research championed by so many of you in this room, the tides of America's dangerous gun culture are changing. It has been 12 years since I lost my Jordan. As my family just marked our 12th Thanksgiving without him, the pain is still very raw and very real. And still, more than a decade later, parents all across America are terrified that they will send their children off to school and never see them come home. Terrified that one day they'll be like me, or the thousands of other families also that are grieving the loss of their loved ones to this vicious public health crisis. Parents and children, educators and public health experts all have said over and over again for years that enough is enough. This gets to the heart of why we're all here today, to use scientific research and data to answer the call of families across this country to end gun violence. Our work to legislate for safer communities on Capitol Hill would not be possible without the data-driven work that so many of you here are committed to pursuing. I feel my son's legacy every single day in this work and in your work. And I am immensely proud of what we have accomplished together. A future free from gun violence truly is our hope. Thank you for continuing to fight. And I'm absolutely certain that our efforts are not in vain. Thank you, and God bless.
Please welcome Mayor Muriel Bowser, Mayor of Washington, D.C., in conversation with Jonathan Capehart, Pulitzer Prize-winning journalist and associate editor at The Washington Post.
Hi. Mayor Bowser, we have less than 10 minutes. So, okay. You've been in office for almost 10 years.
Yep.
Can you talk about your mayoralty and how you govern through a public health lens?
Sure, and it's great to be with you and to be with all of you. And I consider it a privilege that the people have given me almost 10 years to serve. I'm in my 3rd term and will serve at least another 2 years. And I think what that has allowed us to do is to see initiatives from start to finish. And we have been able to stand up, for example, our strategies to combat fentanyl, which is a public health crisis. We have governed through the COVID era, and we're still figuring out lessons learned from that era. And we have been able to focus on health in all policies, which I set out to do when I was a candidate for mayor, and we're seeing the results of that. What our overall goal is, though, is for DC residents to live healthy lives where they thrive and live long lives, and to close gaps. On one side of our city, we have a life expectancy of 72 for a black man and 87 on the other side of our city for a white woman. And so what we know is that when we put these policies across government, whether it's our public schools where we have healthy food, or our public housing where we are removing lead paint, these are the types of strategies that will help DC residents live longer, healthier lives.
Now, you mentioned addressing fentanyl, but a major focus area of the Bloomberg American Health Initiative is addiction and overdose. How are you addressing the challenges of residents living with addiction?
Well, I think, and I don't mind sharing this, that during the COVID pandemic, where we reorganized our government to address this public health crisis, at the same time we were experiencing this fentanyl overdose crisis, and we looked back a year into it and realized how many people were dying of overdoses and how we had to put strategies in place. And I think as a government, overall, we are pursuing harm reduction strategies and trying and making sure we're trying the things that work. Now, the people who have died and are dying in the district from fentanyl overdoses don't look like Middle America, or it doesn't look like the problem that Middle America has. And so we had to make sure that our strategies were actually addressing our population, older men primarily, and how we could get to them, get to their homes, get harm reduction strategies, and get care. One of the things that we've put in place and that we're seeing an immediate result is stabilization centers. We have funded and will open another 2 in our city. But this is having also the impact of helping our healthcare system. We saw our 911 call system, our ambulances, and our ERs inundated with people who needed to be stabilized because of overdose or intoxication. And they would go in the ER, they weren't getting the proper care, the right care at the right time, and then they would go back on the street. And so we just saw this cycle over and over again. But it also meant that someone having a heart attack or some other medical emergency wasn't getting to the ambulance or getting the right care at the ER. So these stabilization centers have allowed us to get people in a safe place where they can detox, but then also be in a place where care professionals can get them connected to care. And so in the last year, we've seen a 25% reduction in our fentanyl deaths, which we think is dramatic. But we've also seen more people, because they've been in a stabilization environment, they've been able to, in some cases, establish relationships with care professionals, are getting connected to care. And we're in the process now of working with the community to open another one. But that process of having communities accept these centers of care is also been a learning experience.
And we don't have enough time to talk about that, about that experience. Another area of concern is gun violence. What's been the district's approach to tackling gun violence?
Well, we have a spectrum of services and activities where we address it. And Jonathan, we had a tough year in 2024 and 2023 with crime. We saw it as the perfect storm of pandemic-related things. People being disconnected from jobs, courts not being open, any number of things leading to increases in crime. And we spent a long time working with our legislature to really reset our public safety ecosystem. And we know that the results have been pretty significant. We've had a 35% overall decrease in crime, and that's including homicide, use of guns, robbery, carjacking, which had been our chief problem. all because we really reset and refocused on violent crime. And a lot of it, we've been following a public health approach to violence for as long as I've been mayor. But we also have to make sure that the system includes accountability, and that's what really needed to be reset. Part of what we do also is we have an Office of Neighborhood Safety and Engagement where we've invested millions of dollars with really focusing on the people who are committing crime in our city. And it's a small number of people. And unfortunately, it's that small number of people over and over again who are creating the most problems in neighborhoods. So we've been focused on that group, how to connect them to behavioral therapy, how we subsidize employment, and also how we treat trauma in communities for people who are committing crime, who are victims of crime, and the people are attached to them. And we think over time that's going to help. But getting more people connected, and I also think behavioral health care is a spectrum. Some people are on the deep end of the clinical side. Other people, if you connect them to life coaches and navigators of systems, they will be able to connect to opportunity.
We're in a room filled with public health trained folks, a room filled with them. So what's your pitch for why they should work in local government?
Oh, local government's the best. And I mean that, and especially this local government is the best. DC is unique. You've heard me say this 1,000 times, but we are a city, a state, a county, a school district, a jail system. We do it all, unlike a school system that the mayor manages and controls. And so there are literally 14 of us, me and 13 council members, who make decisions about a $20 billion budget. So there are ideas that I can have, or you could have, that we could implement in sometimes the space of 6 months, but certainly one budget cycle, and try things. Like sometimes we try things that don't work, but then we try something else. And you can do that in local government. We also are a great place to live. There are people who come in local government, especially, like times like this and transitions that start looking for an exciting government opportunity. And DC is hiring. We are especially hiring behavioral health experts. We need more behavioral health experts in our schools, for example, to meet our own goals of having kids and families connected. We see that as an important link.
That's hilarious, because I literally wrote down, sounds like you're hiring. All right, Madam Mayor, we have less than a minute left, so I'm going to take moderator's prerogative. You are in your third term, nearly 10 years, as you said. Yep. You were able to actually start and see the progress of things you have implemented. Going to run for a fourth term?
We've done a lot of things. We have a lot of things to do. And I'll tell you the reason I ran for a third term.
In 25 seconds.
In 25 seconds. We had to, I feel very strongly about bringing the city back from COVID, revitalizing our downtown, getting people back to work, making sure we have a strong economy. Now I feel very strongly that I get the city through this transition, but lots of people have great ideas, and I'm committed to the city more than anything.
Actually, in the 1 second we have left, I'm looking forward to the next presidential administration.
I've been here before, be here again, and this is what I know. I will be here in 4 years. So I'm gonna work with, it's our job to work with whoever the people send us, and that means the president, the Congress, and we'll approach this one like we did in 2017.
Muriel Bowser, the 8th mayor of the District of Columbia. Thank you very much.
Please welcome Congresswoman Rosa DeLauro, U.S. House of Representatives, Connecticut's 3rd District.
Good morning, everyone. I am honored to be sharing this stage today with so many public health leaders, people I admire and respect, including Joshua Sharfstein, director of the Bloomberg American Health Initiative, Dr. Francis Collins, where we worked together effectively when he led the National Institutes of Health. Secretary Xavier Becerra, who showed such commitment to those we served at the Department of Health and Human Services. John Feinblatt of Everytown for Gun Safety, who has led the way on advocating for common sense public safety measures like Ethan's Law, and my co-conspirator, Congressman Brian Fitzpatrick, who has worked with me for years to improve access to screenings and care for women with breast cancer. Since 2018, this event has convened the preeminent public health and policy experts from across the nation, drawing on the experience and leadership of Mayor Bloomberg and his foundation's strong partnership with Johns Hopkins University. My thanks go to Mayor Bloomberg for launching this initiative, which now supports over 50 full tuition MPH and Dr. MPH scholarships each year, placing fellows in organizations across this country to work on 5 critical focus areas: addiction and overdose, environmental challenges, adolescent health, food systems, and violence. These issues are all crucial aspects of public health and ones that I have been working on in the Congress for many years. I'm grateful to be here with everyone today, from the faculty at Johns Hopkins, to my fellow speakers, to the organizers and attendees of this conference. You are on the front lines of America's public health battles, and I am honored to be with you today to have the opportunity to share my thoughts on our next steps as a country. I believe that a strong public health system with the capacity, data, and leadership to both respond to crises and to prevent them is essential to the future. When I was diagnosed with ovarian cancer in 1986, it was early detection combined with modern radiation treatments based on decades of scientific research from public health research institutions that saved my life. I say as often as I can, I am here by the grace of God and biomedical research. Not only did these measures save my life, they changed the course of my life. I decided to run for public office to have an impact on women's health, poverty, and so much more. I shaped my priorities in the Congress, including fighting for the child tax credit that is so important for the middle class, working people, and for the vulnerable families in this nation. Today, I'm asked to speak on the role of politics in public health and bridging the divides that face us. And those gaps could not be larger. I must be frank about the challenges ahead. The results of these elections were not what I or many of us were hoping for. But I respect that Donald Trump won the election and won the trust of many voters. However, I do not respect the selection of RFK Jr. as health secretary. Well, public health is not a game where we can walk away from a bad hand or simply wait for our next turn. It is a constant struggle, which impacts the daily lives of over 330 million people. And if we do not do our jobs and advocate for them, no matter how difficult, nothing will get better. It is more important than ever that we look beyond partisan divides for opportunities to work together. And I promise there are still opportunities. I just completed an international trip with Chairman Tom Cole of the Appropriations Committee, where we built out a very strong working relationship, including strong support for the NIH, for Down syndrome and other health research initiatives. In fact, there is far more teamwork and bipartisanship in Washington than the 24/7 political noise machine would have us believe. Public health has the advantage of occupying the most common possible ground. We all have a brief time on this earth, and we all want ourselves and our loved ones to live the longest and healthiest lives that they can. We must use this fact to find the issues that both sides can agree on. The new administration and their appointees will have priorities that are different from many of the ones that I would choose. But as an advocate, not a partisan, I believe that with new challenges may come new opportunities. We can take this time to look for blind spots that have been allowed to linger in our public health system. For example, I'm already considering opportunities that some of the president-elect's potential appointees have discussed regarding our food safety system, which is a Bloomberg Initiative focus area and a crucial input to public health, to use evidence to close loopholes that let corporations self-certify additives and ingredients as safe without sufficient testing. We will have opportunities to focus on preventive care and the impacts of chronic disease, especially beginning in childhood. These are just a few of the areas where I believe cooperation is not just possible, but essential. As a starting point, we must stand firm about the importance of science, not just a word, but as an active process, a constant process of gathering new evidence, testing and retesting our ideas and learning. If we have learned anything from recent years, it is that we must communicate the importance of scientific policy making more clearly to the public and find ways to combat misinformation without shutting down the conversation. We must also stand firm on building a public health capacity and defending key programs and authorities from short-sighted budget cuts. When RFK Jr. claims that as health secretary he would fire 600 NIH professionals on day one, I'm horrified at the scope of those impacts. Just a couple of weeks ago, I listened to the head of the NIH, Dr. Monica Bertagnolli, as she talked about the value of the BRAIN Initiative and the breakthroughs made possible by new imaging, giving a physical and physiological picture of what happens to the brain in various mental states. She also talked about the significant progress that has been made in expanding clinical and preclinical trials to include women, an issue where I have led the fight for years. All of these breakthroughs were made possible by consistent levels of funding and targeted increases focused on key objectives. All of those breakthroughs and countless future ones would be at risk with a new administration. RFK Jr. has also said that it is time, and I quote, "give infectious disease a break for about 8 years," end quote. There could not be a more dangerous idea. If we cut back key research programs and lose our progress on innovative therapies, then plain and simple, people will die. The stakes are very real. We have underinvested in public health infrastructure for decades, and the COVID pandemic showed us just how unprepared we were for a fast-moving challenge at a national level. We must protect vital funding and research that helps us to collect data, to modernize our systems, and to retain qualified personnel in key positions. And as we approach the appropriations process for 2025, we need all be mindful of where they may be placing the cuts and stand up and fight back against those cuts to public health. Also on day one, Kennedy claims he will advise the Trump administration to stop all water fluoridation, which has reduced tooth decay in children and adults by nearly 25%, according to the Center for Disease Control and Prevention. And he will amplify his already deadly vaccine skepticism. He's already claimed that a miraculous COVID vaccines were, quote, the deadliest ever made. His record of disinformation and death is long and global. In 2019, he visited Samoa and spread misinformation about vaccine safety, contributing to a measles outbreak that began a few months later and resulted in the deaths of 83 people, mostly children. His organization, Children's Health Defense, has an advisor named Wahome Ngare, who has argued that contraception and health education are part of a global plot to reduce African fertility. It has supported efforts to ban 5G cell phone towers in South Africa over bogus health concerns, and paid a British politician to speak at a European conference opposing pandemic measures and promoting vaccine skepticism. He has even questioned the science behind the AIDS epidemic and insulted its victims by claiming that it was not related to HIV, but instead to environmental toxins and recreational drug use. For a final clarifying perspective on the risks we would face under his leadership, I turn to Scott Gottlieb, Donald Trump's first FDA director, who said about RFK Jr.'s nomination, and I quote, "We're going to start seeing epidemics of diseases that have long been vanquished, and God forbid we see polio reemerge in this country." This is where we are at. The stakes of this fight and the stakes behind every decision that the Health and Human Services Secretary has to make are deadly serious. We must never lose sight of that fact and the people who need our help the most. Good public health administration can be the difference between life and death for many Americans. Our broken healthcare system works best for those who are already well off, for those who are uninsured, chronically ill, or unable to take time off for a treatment, or a simple illness or injury can mean their lives quickly spiral out of control, saddling them with skyrocketing medical bills, even as their health declines. This is why public health efforts are so critical. Poverty, chronic stress, and pollution are real medical threats that exacerbate or directly cause many distinct ailments. These social determinants of health shape our lives in ever-present, often unnoticed ways, setting invisible limits on how healthy we can truly be and the very quality of our lives. I firmly believe that improving public health is inseparable from improving the daily condition of people's lives. This is the fault line with the new administration and where they want to go. We know their record, their efforts to eviscerate the Affordable Care Act and other health initiatives that expand coverage. They do not want to provide the resource or support to communities and neighborhoods, especially those who are impacted by pollution or historic inequality. That will be up to us. That is why I will continue to champion investments in the core capabilities of public health, from data to lab capacity to growing the public health workforce. Good data, good personnel are essential, helping Americans everywhere live healthier lives and contributing to global health resilience. I thank you all once again for inviting me to speak today. I look forward to hearing about the ideas that come out of this conference, and I expect to continue these conversations with many of you very soon. Our mission is there. We have to just take hold and move forward. Thank you very much.
Please welcome Dr. Ellen J. MacKenzie, Bloomberg Distinguished Professor and Dean at the Johns Hopkins Bloomberg School of Public Health.
Well, good morning, everybody. And it has been an amazing morning, and I'm sure you'll agree with me. And there's still much more to come. But it's not every day we get the chance to hear from so many exceptional public health leaders. Thank you to our guests, our faculty, our moderators, President Ron Daniels, and, of course, Michael Bloomberg. Mike's vision and his unmatched passion for and investments in public health are the reason we are here today. In 2016, Mike made his transformational gift to create the initiative, and in 2018, our school held the first Bloomberg American Health Initiative right here in Washington, D.C. At that time, there were many public health challenges confronting America's health. Right before the first summit, we learned that life expectancy had declined over 3 consecutive years here in the U.S., the first time in a century since the great influenza pandemic. Now, the operating premise of the Bloomberg American Health Initiative was that public health and its champions had something to offer this unwell nation, including new ideas, new solutions, new evidence, and perhaps most importantly, boundless energy to enable change. Our fellows and faculty took that mission to heart, developing extreme risk protection orders and fentanyl test strips, among many other innovations. And then the most recent pandemic hit. The COVID-19 pandemic did not just kill more than 1 million Americans, it revealed that the many divisions in our society and put public health under a harsh spotlight. Many of the fellows and faculty of the initiative saw the pandemic's brutal impact on other health challenges, including overdose, violence, and adolescent mental health. We had to develop new playbooks, from sharing data with pediatricians to combat absenteeism, to working with adolescents about cleaning and greening their neighborhoods. We had to persevere through harassment of public health workers and misunderstandings of how public health can and must continue to work and connect with their communities. Today's moment brings a different set of challenges. And I know many of these challenges are top of mind for all of us. But it's not like we can look back and say, well, we had it easy. From the beginning, the Bloomberg American Health Initiative, it has been challenging. And every time, you have heeded the call. America needs public health solutions now so more than ever before, and the initiative is a vital network to provide them. Your voices and your actions will matter deeply in the years ahead. Your country needs you to stand up for science, to share your best evidence, and to advocate for policies that protect health and advance equity. The initiative and this summit provide a foundation on which we can build a brighter, healthier future for America. And we all know, and we'll hear this over and over again, our best work is done in partnership. So thank you again, all of you, for being here, for all you do, all you keep doing, and for forging all these all-important connections with each other. Thank you.
I'm Ariana Yet, and I'm a Bloomberg Fellow. I'm also a senior procurement analyst at Chipotle Mexican Grill, where I help manage our food sourcing and production. Chipotle sells a lot of burritos, which means we buy a ton of food. That couldn't be possible without our suppliers, our farmers, processors, and distribution partners. For decades, restaurants across the country have used unsustainable agriculture methods like monocropping, excessive use of water, and heavy pesticide application. That's the easy way out. We have to find a better way to build sustainable food systems, meet the needs of our growing population, and preserve our planet and its resources. My job puts me at the forefront of sustainable agriculture. Our mission is rooted in the idea that we want to serve food that's good for you and good for the planet. So I spend a lot of my time thinking about how we can better support regenerative farming practices of commodity items like rice, beans, and corn. I also work to develop crisis management strategies to make sure that we continue to serve our clients responsibly sourced, classically cooked, wholesome food. As natural disasters continue to impact communities around the world, my team and I work closely with our agriculture partners to develop alternative crops or better crops to ensure your order tastes the same or better every time. Working at an organization with more than 3,600 restaurants in North America, Chipotle has always allowed me to have a large network of collaborators, but the Bloomberg Fellowship has allowed me to grow that even further. Having a community of public health experts has taught me the skills to develop more robust food systems, improve consumer health, and ultimately cultivate a better, healthier world.
Please welcome DeJuan Strickland, community leader and philanthropist, in conversation with Yasmin Tayag, staff writer at The Atlantic.
Hey, DJ.
Hello.
Thanks for being here today. We've got a lot to talk about.
Definitely. Great to be here.
So your initiative, Team Tech Boy Lunch Heroes, it's a fundraising effort to pay off negative lunch balances for school children. But it grew out of your work as a comic book artist. I want everyone to know, DJ is 16, he's a sophomore, and he's already done so much. Can you tell us about your work on the comic books and how it led to your focus on school lunch?
Absolutely. Well, just for starters, for my comic books, Tech Boy and Science Girl, I was inspired by Chadwick Boseman and his role in the Black Panther movie. And after seeing that movie, it made me realize that there was a lack of positive Black representation in movies, TV shows, and books. So in order to increase my representation, I decided to create my own comic books that have a focus on STEM and have a African-American male and female protagonist. But, yeah. So then taking that and moving on to Team Techboy Lunch Heroes, I was inspired to create Team Techboy Lunch Heroes after an incident in the 4th grade where unfortunately my lunch balance went into negatives and I didn't have enough money to eat lunch that day. And so I had to sit at a table and watch other kids eat their food, and I couldn't eat anything. And that moment just like really stuck with me. And you know, after I made my comic books, I had this like platform, social media following. I wanted to do something to make sure that other kids don't have to experience that same unfortunate incident that I did. So that sparked my initiative, Team Techboy Lunch Heroes. And from there, I've been taking a portion of my comic books and putting it into my initiative to help fund it, and also through GoFundMe as well. And so far, we raised over $40,000 for that.
That's amazing. That's so many school lunches that school lunch balances that you've paid off. You know, I can imagine that not everybody here really knows how school lunch works anymore. Tell us what it means to have a negative lunch balance, and how does that affect kids?
Right, absolutely. So with a negative lunch balance, or lunch balances in general, a parent will go and put money on their kid's lunch account. And lunch balances are fully digital now, so they might have like a lanyard or some sort of digital way to be able to pay for their lunch. So if their lunch balance goes into negatives, unfortunately they won't be able to eat at school. And even further than that, they won't be able to move on to the next grade until the lunch balance is paid off. Yeah, right. So it's definitely a prevalent issue that, you know, really needs to be worked on and focused on.
Tell us what you have accomplished so far. You said you'd raised $40,000. You know, how many kids did that help?
Yeah, with that, first I worked on raising money to pay off offset the negative lunch balances at my old school, which I was able to do. And with it, I was also able to create a pool of money so that anytime a kid has a negative lunch balance, the school can pull from that pool of money, and then that kid will be able to eat. And that has actually helped a lot of kids so far. And even the vice principal of the school went and told me that because of what I did, when a kid at school didn't have enough money to pay for their school lunch, they were able to pull from that pool of money, and they were able to eat pizza that day, and they even got an extra slice, which was great. Absolutely. And I was also able to raise enough money to eventually pay for the entire Hazelwood school districts and offset their negative lunch balance as well. So, yeah, even further.
DJ, you've already done so much amazing work, you know, helping the kids in your school district. You know, what are your goals for the future of school lunches beyond paying off negative lunch balances? What do you hope to see?
I definitely hope to see a free school lunch for students because it's just very important, absolutely. And I mean, I just believe that kids need to eat. Like, how would, like, just go into more detail about that. Like, kids are expected to perform well in school, get straight A's, like do great in their classes, learn a bunch of information, so that they can be successful later on in life with whatever they want to pursue. But how can they do that on an empty stomach? It just doesn't make sense to me at all.
You've mentioned to me that for some of these kids, school lunch is the only meal they get a day.
Absolutely.
And you know, what do you think it'll take to achieve this goal?
Achieve this goal, I think it would take support from both the political parties just to come together on this issue, because this issue is not only just for like communities that, you know, have like less money. It's also for like more wealthy communities as well, also have to deal with a negative lunch balance. So it's on both sides too. So I think that since both sides are affected, I think that that's an issue that both can come together on.
Sure, I think kids going hungry is something everyone can agree on. All right. Problem we need to fix. Thank you, DJ, for being here.
No problem. Thank you.
Hello, my name is Erin Hager, and I'm an associate professor in the Department of Population, Family, and Reproductive Health. I'm also a member of the Food Systems for Health Steering Committee. In the inaugural summit, we introduced 5 actions in 5 years, a series of recommendations for lawmakers and federal agencies to improve health. Today, we will revisit those actions in each focus area, taking a look back and examining where we are today. My research focuses on USDA nutrition programs with an emphasis on school meal programs. Currently, I'm funded by the USDA to develop measures of perceived school meal quality and cultural responsivity, and by the Bloomberg American Health Initiative to understand barriers to procurement to local foods and school meal programs. Significant progress has been made in this action in the last 5 years, particularly with respect to school meal programs. For example, universal free school meals have been passed in 8 states, such that all public school children in those states have access to healthy school meals. Federal policies have supported the expansion of the community eligibility provision, which supports free school meals for all children attending schools that serve lower-income communities. And finally, changes have been introduced to improve the cultural relevance of school meals and to make school meals even healthier than they were before, with more changes coming in the next year, including limits on added sugar. Even with all of this progress, there continue to be opportunities to expand access and improve quality within USDA nutrition programs. And now, please welcome back Yasmin Tayag, staff writer at The Atlantic, along with Robert Campbell, Vice President of Policy at Feeding America, and Kelly Case, Senior Staff Attorney with the Indigenous Food and Agriculture Initiative.
Kelly and Robert, thank you so much for being here.
Thank you. Thanks for having us.
As everybody in this room knows, a key to the future of food is food security, but that doesn't just mean handing out food to people in need. Lasting solutions require serious engagement with the communities that are being served. Kelly, in your work with IFAI, you've encountered some specific needs of Indigenous people when it comes to food security. Could you tell us about that and what that looks like on the ground?
Absolutely, and 10 points for getting the acronym right on the first try. Let's start with some background, right? 28% of Native households in the US are food insecure, as per the end of July GAO report that I last read. And that's compared to 13% of national households. Now that's due to a myriad of reasons, not least the centuries of federal Indian policy, and I won't give you all of that. I couldn't do it in 10 minutes, maybe 15, but definitely not 10. But the high points are this series of policies that are focused on separating us Native citizens from our land, our resources, our food, our traditions, our culture from each other, right? Traditionally, historically, food policy has been made about us and for us, but not necessarily by tribes, tribal citizens. We see a huge shift in that as we work today. So all of those things together, food policies that are flexible and driven by tribes are often far more successful, right? Tribes are sovereign nations. They've been here since time immemorial. We've been feeding our folks since time immemorial. We know how to do it. There are 570 plus tribes, right? So there's not going to be a one-size-fits-all solution. Finding those opportunities for flexibility and specificity that are tribally driven are always more successful. IFAI gets to be the subject matter experts supporting tribes, tribal producers, tribal governments in their work to do that.
Could you tell us a bit about programs, specific programs that have worked and those that haven't?
Yes, okay, I can point to, in the 7.5 minutes, tribally specific programs are things like ones where tribes have control of what they get to do and how they get to feed their people. I've gotten to see examples of tribally driven solutions that are revitalizing community gardens that include traditional plants, but they're planted on the health care facilities landscape, and they have raised beds so their elders don't have to bend down to get to stuff. And guess what? While their elders are there, their daycare is getting to come over and interact with their elders on this traditional plant. So we have these very specific tribal-driven solutions, but that is absolutely recreatable for other tribes, right? Maybe that's not your traditional food, maybe that's not how your healthcare facility is set up, but you have elders and you have daycare and you have traditional foods that you want to reconnect. All are options for how you want to do it for your own folks.
Great. Robert, how does Feeding America approach such a complex task of improving food security in indigenous communities?
Great, thanks, Yasmin. And good afternoon or morning. I'm glad to be here. So Feeding America, our vision is an America without hunger. And to do that, we work with a network of 200 food banks, 60,000 partner and faith-based agencies, soup kitchens, food pantries, things like that, and 21 statewide food bank associations. So in order to understand how to address food insecurity, we think it's best to ask people who are facing food insecurity, who are the experts on that. So we just in September released our third annual report called Insights, an Insights report that asked a representative sample of individuals who currently or formerly were facing food insecurity, what they need to thrive. I won't share all of that with you. You can check it out at feedingamerica.org/elevating voices. But I want to target a couple of themes that'll help get to this point. Four major themes jumped out. Prioritizing dignity, expanding opportunity, improving health, and increasing access. I'll focus on two of those. First, around improving health. Neighbors agreed. Neighbors is what we call those individuals who we work with. They agree that eating healthy food that adheres to cultural and other preferences helps support strong physical and mental health, especially among children. They are very aware of the impact of food insecurity on physical health, diabetes, and heart disease in their communities, and on mental health like anxiety and depression. But here's an important statistic I think is worth sharing. 71% of those individuals surveyed said they want to eat healthier, but they cannot afford to do so. Right, the foundation of so much that we'll talk about today and that underpins the health of this country is around making sure people have access to the healthy food that they know they need and they say they need to thrive. And the other point I want to highlight quickly is prioritizing dignity. Neighbors know what best foods will meet their household needs and cultural preferences. 84% of those surveyed said it's important that anti-hunger policies support people's dignity and choices in what they feed their families. They do not want to see restrictions. They want to have the resources to purchase the food they know they need. So those are under the process that we go through to address food security, and whether that's in Native communities or in all communities, is by going to individuals and asking what they need. And as part of our survey, that does include many of our Native partners and Native communities. We have a director of Native and Tribal Partnerships that's on our staff that has helped deepen our relationships with groups like IFAI, through our network food banks, to partner with those tribes and tribal communities in their areas to figure out what works best, right? If it's providing resources or support around community farming programs, we will help make that connection. If it's working on large federal nutrition programs, commodity-based programs, many of which are in one particular, the food distribution program on Indian reservations, there's some that are designed specifically to target those communities. We'll work with that as well.
Sure, and Kelly, I know that IFAI, I know that IFAI and Feeding America recently collaborated. Could you tell us about that initiative?
We can sure try. And poor Mark, who answers his phone on his day off every time I call him, was the start of this particular collaboration, yes. Recently, there was a rare house disruption when it comes specifically to the food distribution program on Indian reservations. FDIPR for the cool kids. You can all count yourself as cool kids now, and we'll save some time. So in this FDIPR program, food is shipped from USDA warehouses to locations. We call them Indian Tribal Organizations, or ITOs. These shipments were disrupted, right? And it was months and months. We're barely getting back to where and this started in, May is when this started happening. And so huge logistics issue, right? And you think logistics issue, we can fix that. But what the result was people going hungry in these communities who depend on these resources, who depend on this food, which, by the way, is healthier and more culturally appropriate than a lot of other things they have access to. There's traditional foods in this package they may not be able to get other places. Culturally relevant foods, fresh produce in a place like Alaska where it might be really expensive or difficult to get fresh produce. These deliveries were disrupted, people were going hungry, right? And there's not a fast solution in policy all the time. But what there is a fast solution is, and with organizations who know what they're doing and know their communities and can act really quickly to get food to those folks who are hungry. And that's where we got to work together on those things.
Yeah, so in this case, Feeding America, again, our network food banks have the reach to cover the entire country, right? And that certainly includes Indian country as well. So as we started hearing about this in partnership with IFAI, with tribal partners, and then eventually starting to hear from our network food banks, there's a senior commodity program that was also impacted by this. We stand ready to support in times of disaster, whether that's natural disaster, maybe man-made disaster. So we were there. So yes, poor Mark answered the phone calls whenever needed, and kicked into gear, right? Making those connections locally. A lot of times, again, we want to feed people today, right? We know they need today. We will work together, and we are working together. I think we'll end on a question on this of long-term solutions. But we wanted to make sure that tribal partners had connections to their local food banks. Is it a temporary need? Were there certain resources that we can connect to make sure that they had the resources throughout the disruption?
Right. Well, we've got 1 minute to address the big question. We've talked about addressing acute shortages, acute needs, but we want to talk long-term as well. What are the most important sort of policy-based efforts geared toward addressing food insecurity?
We won't get to them all, but I'll point you towards the research. For some light reading later, the Native Farm Bill Coalition, nativefarmbill.com, has produced something called the Gaining Ground Report, which has over 150, I will not quiz you on them, priorities from Indian country around the Farm Bill. For those of you interested in nutrition, Control Find is your friend. You're looking for Title IV.
Great, and I'll pick up on that. So the Farm Bill. I'm sure you have heard about, we'll hear about that, and while we only have a minute to cover a 4+ year process that's still in the works, it is a critical opportunity to make the permanent investments that we think and that tribal leaders and neighbors of ours tell us they need. Quick resource for us, feedingamericaaction.org/Farm Bill. Can look at some of our priorities. It gets very specific, but I'll highlight a couple. One, listening to tribal partners. Looking for tribal parity, did I get that right? Across programs, making sure that tribal communities can run the programs to do so in a way that will work for them. Big programs I know have come up already and will again. The Supplemental Nutrition Assistance Program, or SNAP, the foundation for our country's commitment to addressing food insecurity, needs to remain strong. Benefits need to remain strong. Resources that people tell us they need should be there, while protecting their ability to choose what foods are right for them. And other commodity programs, the Commodity Supplemental Food Program, the Emergency Food Assistance Program, or TFAP, the Tribal Commodity Program, all of those are a win-win. It helps farmers, it helps the whole food supply chain while addressing food insecurity in this country.
Great, thank you so much. We'll have to leave it there. Thanks for being here.
Please welcome Patricia E. Harris, CEO, Bloomberg Philanthropies.
Good morning, everyone. As Mike said earlier, we're here today because we all recognize the power of public health. The Bloomberg American Health Initiative is tackling persistent challenges with greater creativity and resolve than ever, including through the important work the fellows are leading at the community level. These efforts continue across the country full speed ahead, and for all of us on the Bloomberg team, it's an honor to partner with you. 8 years ago, this initiative was born out of collaboration and partnership. So today, I am so pleased to introduce a very special guest who's a longtime collaborator and partner of the team at Bloomberg Philanthropies. In fact, before he became senator, he was a member of our foundation's board of directors, back when he was one of the most dynamic and effective city leaders in the country. As mayor of Newark, New Jersey, he joined Mayor Mike Bloomberg in our national coalition for gun violence prevention, Mayors Against Illegal Guns. And as senator, he's a member of a key Senate Committee on Agriculture and Nutrition and a strong advocate for one of the focus areas of the Bloomberg American Health Initiative, promoting local food systems' access to nutritious foods. So we're grateful for his leadership. We're very fortunate that he could be here today, and we're so happy to welcome him. Please join me in welcoming to the summit our partner in public health, New Jersey Senator Cory Booker.
You're awesome. Hello, everybody. I cannot tell you how grateful I am to be here today, because I feel this incredible sense of urgency, because like every one of you, I love my country. We are all patriots in this room, and we're dedicating ourselves to the idea that we belong to each other, that we're trying to create a more perfect union. But if that's the case, if we are one nation under God, if we are fighting to put more indivisible back into this one nation under God, if we believe that we still share common cause and common purpose, the number one purpose in our country has got to be correcting the outrageous absurdity that in the United States of America, the most powerful nation in the world, we have some of the worst health outcomes. That we spend more money than any other nation on so-called health care, but it's really disease care. 1 out of every $5 in our economy is being used to treat sickness and illness. 1 out of every 3 government dollars being spent on the federal level. It's absurd. We have to start having a truth-telling time in America. The number one cause of death in our country, not natural disasters, not domestic or international terrorism, the number one cause of death in our country, causing death and disease and suffering, is diet-related diseases. We have a food system in America that is literally killing us. It is our greatest public health threat that we're not talking about. And so here are some truths that should outrage Americans. Number one, we are the leading sprayers of chemicals on our food, well out of proportion to other nations. Think about this. We use over 1 billion pounds of pesticides in the United States each year. This is nearly 20%. We're 4% of the globe's population, but we use 20% of the entire globe's usages of pesticides sprayed on our food. And 1/3 of those pesticides are banned from our peer countries. The massive overuse of toxic pesticides harms not just our environment, but it's a public health threat to us when we consume the foods that are sprayed. And it especially threatens our children, our elderly, and our farm workers. And it's not just pesticides and herbicides. We also allow toxic chemicals to be put in as food additives, dyes, preservatives, emulsifiers, sweeteners, all into our foods. Some of these chemicals we know are linked to cancer rates, which are exploding all over our country. They're linked to hormonal disruptions and other adverse effects to our immune systems, our nervous systems, and attention deficit and hyperactivity to our children. We are allowing this to happen and not seeing any kind of protection in our country to protect those vulnerable people who are suffering. And these chemicals, too, are banned in other countries. And so we look at that alone, but when we realize that these chemicals and the foods available to our population are overwhelmingly ultra-processed, addictive foods that are proliferating in our society. Think about this. Most of our supermarkets, when you walk into it, 71% of the food available is ultra-processed, sugar-filled, addictive foods that were chemically altered to be more addictive and more attractive. 2/3 of the diet of our children and our teenagers are these ultra-processed foods. And some people think, oh, it's bad choices, but in communities like mine where I live, choices. My kids go to a local bodega and see a Twinkie product cheaper than an apple, and the apple is unappealing. In my neighborhood, if you want to get a fast food meal, you need $1. But if you go to get a salad, at a salad store, it's $15, $20, depending on what you put on it. The cheap, easy accessibility of ultra-processed foods reflects our bad decisions and what we allow our government to do. In 1960, approximately 13% of the US population was obese. Today, more than 40% of Americans are obese. More than 70% of Americans are either obese or overweight. Even more shocking, 1/4 of our teenagers, our future, are pre-diabetic or have type 2 diabetes. And obesity is the leading medical reason that 71% of our young people couldn't qualify today for military service. And these diet-related diseases don't just shorten life. Remember the untold human suffering going on in our country of millions. They're damaging the quality of life, our productivity, the very idea of what it means to be American. We organized this country. Our imperfect geniuses that were our founders said that we are here for life, liberty, and the pursuit of happiness. Where do you get any one of those inalienable rights? In a food system that drives so much suffering and death, where people are chained to pharmaceutical products to treat the diseases caused by the foods that we subsidize. And every month, we don't talk about it. Every month, diseases like diabetes cause 13,000 new amputations every month in America. Diabetes causes 5,000 new cases of kidney failure in America. Every month, 2,000 new cases of blindness happen in America, in our country. Life, liberty, the pursuit of happiness, you cannot have them in a system designed for people to fail. I believe the main reason we find ourselves here is because we have allowed the majority of our food system to become controlled by a small group, small handful of big multinational companies who prioritize profits over public health. Let's call it like it is. These big food companies carefully formulate and market cheap, ultra-processed foods that are high in calories and have minimal nutritional value, often targeting their advertising of these products to our children. Their standard is not, let's put products out that improve well-being and improve health, that our customers' well-being is our #1 priority. No. They want to shovel as much of these products that they know are unhealthy, as much as possible, into the public, even though they're clinically proven to make us sick. And then these companies tell us that the only thing we need to do is move more. They say that obesity and diabetes are somewhat an individual moral failing, and that they represent a lack of willpower amongst Americans. I love watching Soul Train when I was a kid and had this most beautiful afro. You watch Soul Train from the time it founded, and that great line, I would dance now, but my staff would not ever let me come back. You see how thin the people were. In my community, the black community, which has some of the highest rates of obesity and suffering and death. The changes in our agricultural policy over these years has been driving it into neighborhoods like I live in, a predominantly black community. This is violence. It's the #1 killer of Americans and black Americans as well. And them telling us that the problem is us and not them is a lie. It's not a moral failing. The moral strength of this generation isn't worse than my grandparents' generation. It's that the system has changed and it's rigged against Americans. This corporate greed and Americans' government's failures to hold corporations accountable and set standards, that's how we got here. It is a policy failure that has to change. Our dietary guidelines tell us that 50% of our diets should be fruits and vegetables, but less than 10% of our federal funding for agricultural crops goes to farmers growing those healthy foods. That incongruency is not just illogical, it's poisoning us. We should have an alignment between our dietary guidelines and what we support and subsidize, because we're subsidizing sickness and the pharmaceutical industry now. This is a policy failure because the vast majority of our federal agricultural subsidies go to a small handful of crops such as corn and soy, which end up in those cheap ingredients in ultra-processed food. It's a policy failure because for 50 years we've stopped enforcing our antitrust laws, which has not only helped to create our nutrition crisis, it has been a disaster for American farmers. Since the 1970s, we have lost more than 500,000 farms in America. They have higher suicide rates as farmers than we do as the American public. The loss of family farms has destroyed rural America in the sense that it has led to an exodus of residents and jobs, hollowing them out and depopulating them. And for the farmers who managed to hang on, this is the reality for them. 88% of our farm families have second jobs off the farm, and a majority of the income utilized by those families is generated by off-farm income, but they stay on their land. They fight for it. It's been in their families for generations. They love it, but the system is screwing them over. And so where do we go from here? If you know me, you know I'm a prisoner of hope. If you know me, I believe hope is the active conviction that despair will not have the last word. I will not give in to this reality. I will not accept it. It is time for all of us to wake up and to join a larger cause of our country to bring back the ideal of life, liberty, and the pursuit of happiness, to bring back that ideal that we share common cause and common purpose, not to fall into the forces tearing us apart, but to stand together to advance public health. I believe that we can do it. It's a hard battle, but American history is a testimony to Americans coming together and achieving impossible things. And the movement's growing, y'all. It's growing. Concerned moms who simply want their kids to eat healthy food, they're joining the movement. Small family farmers who want to stay on the land and produce food that Americans need to eat, they're in this movement. It's being led by workers all over our food system, from the supermarkets to the fields, who know that a healthy food system will help them be more healthy. It's a movement by the people in this room. That's why I was so eager to be in community with y'all today, because it's tough up there on Capitol Hill, but I wanted to be with you. And so I'm going to keep the fighting, but I know we got a growing posse of people just as committed as I am. I'm going to make sure that no matter who's president of the United States, that we push the FDA to use their existing legal authority to ban toxic chemicals from our foods. And enough of this grass loophole, generally accepted as safe. Forget that. New chemicals, before they're introduced in the system, the FDA can require that they are actually tested and proven before they allow them into our foods. I'll be pushing the FDA, the EPA, pesticide office to stop doing the industry's bidding and start standing up for Americans and protect their health. I'm going to push for the Farm Bill, which I know was just talked about, for that drafting process next year to exponentially increase their investments into USDA programs that prioritize independent family farmers who are growing the foods that Americans most want to eat, fruits and vegetables. And I want to be pushing for policies that are going to continue to focus on the resiliency of our local communities. I'm looking for allies, folks. This is a call for patriotism, folks. This is a Fannie Lou Hamer moment. Everyone here should be sick and tired of being sick and tired. We should be sick and tired of being sick. This is a John Lewis moment. Because John Lewis said, do not sit idly by when the cause of your country is in crisis. It's time for all of us to cause some good trouble. It is a moment of truth. Our founders talked about the ideal of our truth will go marching on, but we said it in our founding documents that we hold these truths to be self-evident. A new generation of Americans has to rise up and speak up and stand up, that we in this generation will again reclaim the American dream that everyone should have access to life, liberty, and the pursuit of happiness. Thank you.
Please welcome Congressman Brian Fitzpatrick, U.S. House of Representatives, Pennsylvania's 1st District, in conversation with Dr. Joshua M. Sharfstein, Director of Bloomberg American Health Initiative.
Hey. Well, welcome back, everyone. I hope after that discussion of food policy, you all had a good snack. Thank you so much, Congressman Fitzpatrick, for being here. You have taken a very interesting path to Congress. You not only served as an FBI special agent and federal prosecutor, but you also are an EMT. You're a Republican, but you co-chair the bipartisan caucus around mental health and substance use disorder. One of our themes today is how we find common ground on issues that divide us.
Yep.
Talk to me.
Okay, where do I begin? How do we find common ground? Well, to start on health, I think the big challenge that we have, particularly with mental health, which is the most underdiagnosed, underrecognized, undertreated, underfunded health crisis we have in this country, that we have to start with the stigma that exists, and it's a very real thing when we address, and we see it all the time in Congress, when we see healthcare addressed, more often than not, it's focused on the neck down and it's stigmatized from the neck up. And I think the key to that is parity. So we have legislation starting in the grade schools, in the elementary school level. It's called the Mental Health Excellence in Schools Act, which basically says if you have an RN in a school, you also need to have a school psychologist. And just creating parity across the board. Kids in particular have a very, very tough time dealing with a lot of the challenges they face in school with the bullying and the social media, shaming and things like that. And it's really, really important that I think we destigmatize mental health and then also make it much more of a normal thing for kids to seek out, because so many of our problems can be nipped in the bud if we address it at the elementary school level.
Great, and sounds like that message you feel resonates
Very
people,
much.
even if they're coming from different kinds of backgrounds. Let me ask you this. There are enormous divides in health across race and ethnicity, between rural and urban areas, and others. How do you see the role of the federal government in making America more fair and just?
Parity. I had a very profound experience. My first cycle in Congress was 115th. I represent just north of Philadelphia. Dwight Evans, my friend and colleague, represents the city of Philadelphia, and there's an amazing eye institute. It's called Will's Eye Hospital, and they had one day a year, where they shut down the center, and it's called the Give Kids Sight program, where they brought in, free of charge, any kid with their parents or guardians that wanted to come in and get eyesight examinations, and I think 35% of the kids that left there left with corrective lenses, which is really remarkable, because when you think about it, if you can't see, you can't read. If you can't read, you can't learn. If you can't learn, you can't graduate. And it makes it's a ripple effect. And this one, getting at this one root cause issue on one day out of the year for all these kids, just giving them the ability to see and therefore learn, was so important.
It is really important. In fact, Johns Hopkins has a major partnership with the Baltimore City schools to make sure that all the kids have access to glasses. And it was interesting because it rolled out in a way that you could study which the schools that got it first versus the schools that didn't. And that intervention alone was almost as impactful on educational success as tutors.
100%.
It was just hugely impactful, which gets to the question of data. One of the things that makes us a little anxious in the field of public health is that people sometimes seem to be showing up with their own data, and not just that they're showing up with their own data, but that data can seem to be coming from, planet Neptune sometimes. How do you think of this challenge of getting people together to talk about the problem and seeing it the same way? Even if they have different views on what to do, at least see the problem the same way. How do you think about that?
I mean, where do you begin? I mean, you can't start a conversation when you can't agree the sky's blue, right? There are certain fundamentals that we have to agree on to even sit down at the table together. How we've gotten to a point where data and science is questioned is beyond me. I think technology and social media have a large role to play in that. You know, way back before any of these technologies existed, if you had some oddball view, you were sort of on your own. Now you can go online and find an entire community of people that share that belief and cause you to act out. That's some of the challenges we've seen. But we just got to get back to the basics. I think that's the bottom line. Belief in science, belief in data is the only way we're going to solve not just the public health crisis, but world peace, literally.
Yeah.
Because a lot of it comes down to data.
I understand that you've been supportive of more resources for key data collection on different kinds of issues. I think we all appreciate that. I think without data, it's really hard to know what's working, and public health is firmly rooted in that. So as someone who is trying the word bipartisan doesn't appear in many places, but you are also part of the bipartisan problem solvers.
Co-chair.
Yeah. We want problems to be solved. That's pretty much the essence of public health. We have problems, we want them to be solved. What advice do you have for 500 people working around the country trying to solve problems, trying to figure out how to make sense of this moment?
So our group, as many of you know, there's a continuum of caucuses in Congress. So on the far right, you have the Freedom Caucus. On the far left, you have what's become known as the Squad. And then there's a number of caucuses in between. There's only one, unfortunately, but it's our group that's bipartisan. It's the Problem Solvers Caucus. In fact, it's a Noah's Ark rule. If you want to join, you have to find someone from the opposite party to join with you. Every bill we advance is a two-party solution. We sit together in the center of the chamber during the State of the Union address. We go to each other's districts. We call them district swaps. And basically, the message we advance is that we ought to take the same approach to government that we take towards our personal relationships, that you don't allow the perfect to be the enemy of the good. You take 80% of something rather than 100% of nothing. You try to see the world through the other person's eyes, because every single one of us, based on our upbringing, where we went to school, the family situation we grew up in, pain we may have experienced in our lives that other people haven't, it all affects the paradigm and how we approach problems. We follow the same model, by the way, in the FBI. Anytime we had a time-sensitive crime problem, we always use a kidnapping example because it's the most time-sensitive. Every second that ticks off that clock is another opportunity for the kidnapper to cross state lines, at which point the probability of successful outcome drops exponentially. We would surround the table with people from completely different backgrounds, and we actively sought people identifying our blind spots, because we all have blind spots. It's a part of human nature. And secure individuals actively seek people to identify their blind spots for them. So the problem solvers is essentially the legislative version of that. We don't get a whole lot of attention because we don't fight and argue with each other. Unfortunately, that is what gets the attention. We're people that respect each other as human beings. We're friends. We get to know each other's families. Right. And we actively want to learn from their perspectives because of their different life experiences.
You have our attention. Thank you so much for doing that and for that work and for joining us today at the Bloomberg American Health Summit.
Thank you. Thank you.
My name is Nor Karagoli, and I'm a Bloomberg Fellow. I'm also a lead research analyst at the Policy and Research Group here in New Orleans. I collaborate with state and local governments, community groups, and schools to evaluate programs that improve adolescents' health and educational outcomes while reducing violence and sexual risk behaviors. There are so many new and creative programs to promote adolescent health. What we ultimately want to know is, which of these programs really work? Do they move the needle on the outcomes we're aiming for, especially in settings or with groups that have traditionally not been reached? To find the answers, we use a wide variety of research methods so that policymakers, schools, and other partners we work with are able to find effective and evidence-based programs that demonstrate positive change. My favorite part of all of our projects is data translation, making the findings of a study more meaningful and actionable for the people and communities we work with, so that they can turn our research into impact. By translating complex concepts into practical tools, we help diverse teams foster new approaches, conduct research, and expand the evidence base to support and advance equity in adolescent health programs. My time in the Bloomberg Fellowship Program and my work at the Policy and Research Group has helped me discover more equitable and effective programs and policies to truly improve adolescent health.
Please welcome Cynthia Bissett-Germanata, President and co-founder, Born This Way Foundation.
Good morning, everyone. Good morning. I share my deepest gratitude to Bloomberg Philanthropies for bringing us together to address the most urgent challenges of our time, including the mental health of our young people. An issue that intersects many topics spoken about today, and one that will take all of us working together across fields to address. As president and co-founder of Born This Way Foundation, I have the privilege of speaking with young people every single day. These conversations, along with the research we conduct, are the heartbeat of the mission of our work, which is to empower and inspire young people to build a kinder, braver world that supports their mental health. Today, I'd like to share the importance of what we've learned from young people directly and how their perspectives have helped shape our approach. Also, I heard there are over 300 fellows here today, so hello to all of you. We see you, we hear you, we validate you, we love you, and we can't wait to see what you do in the world. We're working very hard for you. Right now, younger generations are navigating an extraordinary, ever-changing set of pressures. They are keenly aware of the fact that this rapidly changing world, marked by economic instability, social inequities, and other factors, presents an uncertain future. Climate change, limitations on personal rights and freedoms, social media, all weigh heavily on young people, especially those from historically oppressed communities. While we recognize these changes, we're also witnessing something very hopeful. In light of all they're facing, young people are overwhelmingly aspirational and are not short on solutions. We need to ask, to listen, to offer support by giving them the skills, tools, and agency to shape the kinder, braver world they envision. Born This Way Foundation puts this awareness into action through 3 key approaches to keep young people at the center of shaping solutions. First, we center their voice directly in conversations about solutions. Young people are the experts of their own experiences and have actionable ideas for how to support their own community and one another. They don't just need our help, they need a seat at the table. We create regular opportunities to bring together young people and decision makers for open discussions about youth mental health. For example, earlier this year, we partnered with California Senator LaFonza Butler to host town halls, bringing together young local activists and educators, peers, nonprofit and business leaders, to share perspectives on mental health and the solutions that they would like to put into place. From integrating preventative mental health education and services in schools and communities, to leveraging technology to meet the needs of young people. Audrey Wang, a member of our Youth Advisory Board, 17 years old, talked about the need to include young people in the development of social media and other online resources. But she's not just asking to be included, she's making the change herself. After seeing how cyberbullying and social media were taking a toll on her peers, Audrey coded a platform called Effective Cookies, which inspires users to improve mental health through inclusivity and empathy, and has already reached thousands of users to date. Audrey is one of the many youth that remind us that young people don't just have ideas, they have solutions. Encouraging collaboration across sectors and uplifting the innovative ideas developed in spaces like these can directly shape programs and policies. Senator Butler went on to recruit her own Youth Advisory Council, which helped directly influence legislation aimed at addressing systemic mental health disparities in communities. So we center the youth voice. Secondly, we follow the data. You can't solve a problem if you're not talking to those directly affected by the problem. So research is at the heart of our work to ensure every aspect of our programming is evidence-based and informed by a deep understanding of the evolving youth mental health landscape. This year, we're partnering with researchers at Hope Labs and LGBTQ+ youth themselves to explore how online communities impact their mental well-being. Early findings show that LGBTQ+ young people, especially those in rural areas, feel safer and more supported in moderated, affirming online spaces where they can freely express their identities and connect with others who share their experiences. One young person surveyed shared, quote, "I live in a small village and there are not many gay people. Online, I have met several people who understand what I'm going through. It lets me connect with someone and not feel alone." As we examine this intersection between youth mental health and social media, having data on the actual experiences of youth, specifically online, is deeply important. The billions of young people globally are not having a singular experience with mental health. We need data that helps us understand these differences and craft solutions that are responsive to their broad range of needs. By combining research with youth input, we can design interventions that meet young people where they are and build resources they'll actually use. So we center youth. We rely on the data. And lastly, we dream global, but we think local. While national and global policies are critical, the best way to meet the immediate needs of young people often begins at the local level. Across the world, community organizations are already providing life-saving support to young people, whether it's direct mental health services, access to housing, food, mental health services, or just spaces where they simply feel safe and supported. Through Born This Way Foundation's Kindness in Community Fund, we invest in local and community-based organizations, helping them amplify and expand their work, collectively reaching even more young people with a broad spectrum of services, all while creating spaces of safety and belonging. Our current cohort of grantees spans 65 organizations in 10 countries. We've funded over 250. And we are very excited and proud about that. And one of the most exciting things is that we create relationships between these organizations so that they can network and share learnings. One of my favorite moments was hearing a young person describe how they finally felt seen when a local organization provided them with a safe space to share their struggles. It's a simple, profound reminder that community is at the heart of healing. Kindness is at the center of our work, and it isn't just an ideal. It's a tool for empowerment. My daughter, Stephanie, who many of you may know as Lady Gaga, but to me, she's my Steffi. She often says that kindness is a currency that we all have, and we should spend it freely on one another. Our research shows that young people in kind communities experience better health outcomes. Fostering environments of acceptance and understanding helps young people thrive. None of this at all can happen without collaboration. It will take all of us to be willing to not just work for young people, but to work with young people. This work is urgent, but it is also full of hope. When we stop assuming what young people need and simply ask them, we discover that they're already working to be part of the solution. Our role is to listen, amplify, resource, and together we can build a world where mental health is prioritized, communities are strengthened, and every young person has the opportunity to thrive. I thank you, Bloomberg Philanthropies, for shining the light on this important topic, and I thank each and every one of you for the great work that you're doing every day. Thank you so much.
Please welcome Dr. Beth Marshall, Associate Director, Johns Hopkins Center for Adolescent Health, with Jaytoya Mangat, faculty nurse practitioner and director of nursing for Children's School Services at Children's National Hospital, and Priya Bayati, program coordinator, CRISP DC, in conversation with Jamie Ducharme, health correspondent at Time Magazine.
Hello, everyone. Thank you so much for joining us for this important panel on chronic absenteeism and how it relates to health. So Jaytoya, I'd love it if you could sort of set the stage here for us and explain what the CARE-H program is and what it's trying to achieve.
Sure. So we are a unique and innovative educational and healthcare partnership that really sought out to test the integration of school health data into our primary care system. So our full name is the Collaborative for Attendance Resources in Education and Health. And we actually have a graphic that shows how it all works. So at the school level, currently our partner is DC Public Schools. The parents consent to the program, and then their attendance data is sent through the Health Information Exchange. At the primary care level, we receive that data and then do outreach to the families based on the number of days they've missed.
Thank you so much. And could each of you, because this is really a holistic, wide-ranging program, could you each just briefly explain how you and your organizations fit in?
Sure. Do you want me to start? So my focus is on evaluation. I work with my colleague Megan Schutte in the School of Medicine, and we focus on continuous quality improvement, focused on program outreach, consenting process, partnerships, and then we look at attendance outcomes across the program years.
And I, along with my colleagues Danielle Dooley and Jessica Wise, represent the healthcare sector. So we receive the data each month from the Health Information Exchange. I also kind of oversee the flow of that data, making sure all the pieces work, oversee our quality improvement cycles, and then also work closely with our community health workers, who are really the heart of our program. They're the ones that do the outreach to the families via the phone, as well as go out to the schools and the community to really connect with the families and students.
And I'm a program coordinator at CRISP DC, and so our role in this project is really just acting as a conduit of information. CRISP DC is the district's designated Health Information Exchange, or HIE, and those of you who are not familiar with an HIE that's just a secure electronic process in which healthcare providers can view and access patient information. And so in this project, our team works to get that file of consenting students from DC Public Schools. Then we match that file with a list of patients that are on children's patient panel. And then we send that file to children so that they can do their outreach.
Great, thank you. And Beth, I want to actually zoom out for a second to talk about why chronic absenteeism is a health issue. How can missing school affect a student's health both then in the short term and longer term?
Thank you. It's a good question, because typically we think of chronic absenteeism in education, and school absenteeism or chronic absenteeism where a student misses 10% or more of a school year is really an indicator of child health and development. States use it, majority of states use it as an accountability measure for education systems, but really it's a symptom of systems not working for young people. So it's a symptom, systems aren't working for young people. And when we think about education, the risk and protective factors for chronic absenteeism largely lie outside of education. So that's where public health comes in. It's a public health problem because when we think about it, about 25% of students in the US are chronically absent. It affects every state, it affects every district, but it disproportionately affects students within those states and districts, particularly students of color, students whose family experience low income, students who are experiencing homelessness, and students with disabilities. And when we think about health in the short term, if a student's not in a school building, they're not just missing academics. They're missing critical health services. So access to school meals, access to school health services through a school nurse or through a school-based health center,
therapeutic services like OT and PT, school-based mental health services. And when we think about like sort of the longer term, we know that when young people are not in school in the early grades, they're less likely to read on grade level by 3rd grade. And that is an indicator that they may not graduate. We see in adolescence, young people who are not regularly attending school are often more likely to engage in health risk behaviors like substance misuse. And we see in high school that chronic absenteeism is a stronger predictor of high school graduation than test scores. And we know in the long term that young people who do not graduate high school have health impacts across the lifespan. So higher increased risk of mortality and lower life expectancy.
And Toya, do we have any data from the first few years of CARE-H's implementation to show whether it's working, whether it's addressing any of these problems that Beth is talking about?
We do, and there are many things in the program that we are proud of. The first just being the data exchange. Historically, as primary care providers, we did not have a way to see what was going on in the schools. We could go by parent or student recall, but now we actually have real quantifiable data that tells us how many days the students are missing. So from there, we've been able to connect with many families that have also been out of touch with primary care as well as their specialist visits and get them back into care. In our 2nd year of the program, we did start social determinants of health screening as we were doing the outreach, which was very important because we did find that many of the families that had students that were chronically absent also were experiencing food and housing insecurity. So then our social work team was able to connect them with those resources. And most recently, we're really proud that our latest analysis has shown that students that had outreach during our 2nd year of the program had statistically significantly fewer days missed in the 3rd year. So those that we were able to contact in year 2 and potentially provide resources with had 5 fewer missed days in the 3rd year. So that we're really proud of because that's an entire week of school for students and really does make a difference when we're looking at the chronic absenteeism markers.
Yeah, that's really striking. Thank you. And Priya, I want to talk about the ways that data is used to facilitate these health outcomes. I mean, it strikes me that it's pretty unique to use school attendance data in this manner. So are you and your colleagues at CRISP-DC kind of thinking of other unique ways to use data or to share data to further improve public health?
Yeah, certainly. The CARE-H program is definitely a unique project and one of my favorite public health programs that I work at CRISP-DC. But within CARE-H, I have had the opportunity to participate with the National Attendance Data Learning Collaborative, which allowed us to learn and share our work with other states. We've also been in talks about expanding this program since currently this is only a pilot at Children's. And then outside of CARE-H, CRISP-DC does work on utilizing a lot of variety of different unique public health data sources. Most notably being our unique partnership with the DC Department of Energy and Environment, where we work with them to share lead blood level results with providers, DC WIC, and DC Water and DC Public Schools. We also have our social needs program, which allows users to refer their patients to community-based organizations, allows them to search for community resources, and also to conduct social needs assessments. We also are able to parse C codes, which are basically non-medical factors, from these electronic documents that we're receiving from organizations and display that in a separate tab. We also have the social determinants of health pop health reports, which allow our users to visualize social determinants across census tract, ward, or neighborhood. So there really are like a lot of different things that CRISP-DC is working on to make sure we're improving public health.
Awesome, thank you. And we have 40 seconds left, so this is like a speed last question. But okay. I'm curious, we heard so much about chronic absenteeism in the wake of the pandemic. Yeah. We're here almost in 2025. Why is it taking so long to recover attendance?
You know, I mean, I think chronic absenteeism is really driven by a variety of health and social factors, and we bucket them into like barriers to getting to school, aversion to school, disengagement from school, misconceptions. And if you look across each of those categories, the pandemic just exacerbated all of those factors. And so while we've made some progress, we're nowhere near pre-pandemic levels, and it's going to take a collaborative systems level approach. It can't be solely on students, families, and the education system.
Right. Well, thank you all for sharing about this innovative program. Thank you for being here.
Thank you.
My name is Kiara Álvarez, and I am a Bloomberg Assistant Professor of American Health in the area of adolescent health. Young people today are facing unprecedented challenges, but they also bring creativity, insight, and new solutions to complex problems. Yet too often, youth perspectives are dismissed or left out entirely. We have an opportunity now to engage youth across all levels of government. Recently, as part of the Worldwide Open Government Challenge, the US General Services Administration announced a commitment to increasing public participation across federal agencies. The task in the years to come is twofold: to maintain this commitment to engaging communities and to ensure that youth are a priority population at the table. Meaningful civic engagement opportunities also build youth connectedness to their local communities. Youth-serving agencies, such as those represented by our adolescent health fellows here today, can show us a path forward to promote both youth and community well-being. And now, we will move into the portion of our programming focused on the environmental challenges focus area. Thank you.
My name is Melina Giannotti, and I'm a Bloomberg Fellow. I'm also the Emergency Coordinator for the Northwest Portland Area Indian Health Board, which houses our environmental public health program, which serves the 43 federally recognized tribes of Oregon, Washington, and Idaho. Every day, our team works to address health disparities and enhance quality of life for tribes in the region. Emergency preparedness in Indigenous communities is essential to safeguard lives, preserve culture, and protect the natural environment. Effective preparedness strategies benefit greatly by blending Western science with Indigenous knowledge, so that way they can be adapted to fit tribal communities. Tribes have consistently worked to address climate change, as their traditional lands, livelihoods, and cultural practices are tied to the natural environment. They have done this while ensuring that tribal members have access to safe food, clean water, and both modern and traditional medicine. My work through the board focuses on providing tribes with environmental health services through our program. We also ensure they have access to federal and local resources. Through the Bloomberg Fellowship, I have gained a unique insight into what a strong emergency plan looks like. And I have joined a new network of collaborators that I know I can call on whenever I have a question. I am so thankful for this opportunity to learn and share with the tribes of the Northwest.
Please welcome Dr. Robert Hampshire, Principal Deputy Assistant Secretary for Research and Technology and Chief Science Officer at the U.S. Department of Transportation, and Dr. Shima Hamidi, Bloomberg Assistant Professor of American Health at the Johns Hopkins Bloomberg School of Public Health, in conversation with David Zipper, Senior Fellow MIT Mobility Initiative and contributing writer Vox.
Good afternoon. It's great to be with all of you here today, and we're here to talk about what I would consider to be an objective failure in American public health, the US road safety crisis. And I say objective because you can just look at the data. Over 40,000 Americans die in crashes every year, and on a per capita level, Americans are several times more likely to die in a crash than people living in really any other rich country. In Europe, in Asia, we're actually 2.5 times more likely to die in a crash than Canadians, which is a similarly, of course, spacious and car-oriented country. So we're going to discuss a little bit about what some of the reasons for that are and perhaps some solutions. And I'm joined here by Shima Hamidi, who is the Bloomberg Assistant Professor of American Health from Johns Hopkins Public School of Public Health, and Robert Hampshire, the Principal Deputy Assistant Secretary for Research and Technology and Chief Science Officer at USDOT. So Shima, why don't we start with you and focus on road safety to begin. I think that there's an assumption that a lot of road engineers have had for a very long time that wider lanes are safer because there's more room for maneuver if a driver goes a little bit too far to the left or right. And you've done a major project concluding that that's not the case. Can you tell us why?
Yeah, so traffic crashes or traffic fatalities are the #1 leading cause of deaths for people age 1 to 54. US is the #1 in terms of fatalities from crashes, by far 10 times more than any other developed countries. And so a big part of that is coming with street design, the way are designing our street network. This phenomenon, that wider lanes are safer, and most often you end up with streets that are too wide, too encouraging for drivers to drive fast, and no sidewalk, no bike lane, not really opportunities for other modes of transportation. We did test this phenomenon in a national study covering 7 cities, 1,100 streets, and we found that that is not the case. Wider streets are actually more dangerous. They have higher number of crashes, higher number of fatal crashes. So this study has been getting attention. We're working, we got connections with more than 24 cities, 5 states who are interested in working with us to make streets in their cities narrower, from California to Virginia to Maryland, cities all over from Florida. And this is an example of how we can work together with community, with government, to make streets safer, more environmental friendly, and mitigate climate change impacts while providing options.
Yeah, it is getting attention. I saw on, at least on social media, I don't know if you can still use the word tweet, but I saw a tweet about the study that got like 1,500 likes, so it's really making the rounds. Just a question. If you have narrower lanes, whose lives are largely being saved? Is it pedestrians? Is it cyclists? Is it people inside cars? Who benefits most?
Great question, David. So again, we have decades of practicing safety standards that prioritize drivers. And the narrower lanes prioritize pedestrians, cyclists, the most vulnerable users of streets, arguing that if a street is safer for them, then it's safer for everyone. So narrowing lanes will make streets safer, more welcoming for pedestrians, for cyclists, and for drivers as a result. And I want to mention that we also see a huge disparities in different neighborhoods. African Americans are 237% more likely to be killed in a car accident as a pedestrian. And it's because of the lack of infrastructure, safety infrastructure, wider lanes in those neighborhoods. So another part of that is to prioritizing the most vulnerable, marginalized groups of population when you think about street infrastructure and safety.
Thank you. Robert, you do a lot of work with technology, and a lot of work about the connection between technology and safety. I know you've done a particular initiative around what's known as V2X, car and infrastructure communications. Maybe you can explain briefly what that is and why you believe that that's an opportunity to save lives.
Yeah, thanks for that question, David. And really, I'm here to invite this public health community to engage with the transportation, with the Department of Transportation. We've done that. We're partnering with Johns Hopkins School of Public Health in engineering to do transportation work and really seeing particularly the safety and climate impacts as really a public health issue. And part of that approach to safety, and we'll get to the answer, is that we put forward something called a National Roadway Safety Strategy. And it's an all-in approach. You need safer drivers, that's behavior. You need safer roads, you need safer vehicles, and you gotta get post-crash care correctly. Many people, I think it's around 30% of those who go on to die in a car crash were actually alive when EMT arrived. And so when we think about safety and we talk V2X and connectivity, it really is, we lead with safety. And when you have vehicles that are connected, when you have EMT and ambulances that know what's around them, and can they get through traffic lights quicker? Can they get to the hospital emergency room quicker through traffic? And something called vehicle everything communication or vehicle-to-vehicle communication can help facilitate that. So that's a use case of safety with V2X, and there's many others at intersections for pedestrians, for people with bicycling, and those driving a car.
Yeah, and I know your office has done some work around AI and transportation as well, looking at safety impacts there. But if I could, I might ask just sort of like a friendly, skeptical question based on an anecdote in my own experience. I was in Helsinki, Finland, a few years ago, which has seen a sharp decline in road deaths, like 80% plus over the last 10 years or so, 20 years, I should say. And they went a full year without any pedestrian or cyclist deaths at all. So I asked the head of city planning in Helsinki, what role has technology played with cars and infrastructure in saving lives in your city? He said, none whatsoever. We simply slowed down the cars. So I guess we've been living for 25 years in this period of technological Eden, with so much happening in the US around innovation with cars and with infrastructure that's connected. Is it possible it's all a distraction and we just need to focus on the basics to actually save lives?
Great question. The answer is yes, it can be a distraction if done incorrectly. But Secretary Buttigieg really put forward innovation principles that really, we're doing technology, not for technology's sake. At the Department of Transportation, we're focused on safety. And so for AI, for example, we're using AI to help re-engineer the streets so that possibly traffic will be slower, intersections will be safer for those walking, but it really is technology and the purpose of a mission. In this case, that's definitely safety.
That's all the time we have. Please join me with thanking Shima and Robert, and we'll be around afterwards for questions.
My name is Jamie Madragano, and I am a Bloomberg Associate Professor of American Health and Environmental Challenges. The U.S. Environmental Protection Agency must maintain its mission of using science to protect and promote the health of the environment. The scientific integrity of the U.S. EPA is critical to protecting public health. Federal laws like the Clean Air Act and Clean Water Act, statutes with bipartisan origins, have not only saved countless lives, but also trillions of dollars. We have made great progress on this action in the last 5 years. For example, air pollution reductions stemming from regulatory updates issued between 2021 and 2024 will save over 200,000 lives, avoid over 100 million asthma attacks, and deliver over $250 billion in net benefits annually through 2050. These are priorities for all Americans. We need strong EPA science to produce a more resilient economy and cleaner environment. It's about protecting public health.
I'm Ray Samuelson, and I'm a Bloomberg Fellow. I also serve as an overdose prevention specialist with On Point NYC. I started working in this field for deeply personal reasons. One of my close friends died from a fentanyl overdose in 2019, and I didn't know what to do with my grief. So I started working at a needle exchange program. My experience there made me realize that many lives could be saved if people had access to a judgment-free environment where they could safely use drugs, learn about harm reduction strategies, and gain access to effective treatment. After I wrote my undergraduate thesis on harm reduction, I went to work at On Point NYC. When we opened the first sanctioned overdose prevention center in the United States in East Harlem, we faced pressure from protesters and some in the media. They were nervous that such a site might bring more crime to the neighborhood, but I'm proud that we pushed through the adversity and opened the first site in the US. We set a precedent just by opening, and our work is serving as a model for other organizations around the country. And in our first week, we were able to reverse more than a dozen overdoses. Now, I'm pursuing a Master's of Public Health through the Bloomberg Fellows Program because I believe that the connections I will make here will help me and my organization make a difference in the ongoing national overdose crisis. We owe it to our communities, to our loved ones, and to ourselves to keep pushing forward. Because nobody should have to lose somebody they love when we know that together, through the power of public health, we can make a difference.
My name is Brendan Saloner, and I am a Bloomberg Professor of American Health in Addiction and Overdose. Risk of a fatal overdose soars in the weeks after people leave a correctional facility. One major reason is that when people are incarcerated, they are not getting treatment with medications like buprenorphine and methadone that are proven to cut overdose risk in more than half. More jails and prisons are treating opioid use disorder, but these medications are not offered in many facilities. Recent federal actions can help build momentum for medication treatment. These include a regulation that allows facilities to stock their own methadone and treat opioid use disorder as an adjunct to other health conditions, and new opportunities to cover health care in correctional facilities using Medicaid. These actions can save lives. Please welcome Riley Griffin, healthcare reporter, Bloomberg News, joined by Ruth Potee, medical director, Franklin County House of Corrections, and director of Addiction Services, Behavioral Health Network, and Ingvild Olsen, director, SAMHSA Center for Substance Abuse Treatment.
Dr. Olsen, I want to start with you here. You work with such a range of populations in your role at SAMHSA, and I wonder if you could center this conversation by helping the audience here understand why it's so important to think about incarcerated peoples and in this broader discussion about opioid use disorder and expanding treatment.
Yeah. It's such a great question, and Brendan actually highlighted it, that this is a population that has just incredibly high risk of mortality, mostly from opioids, particularly illicitly manufactured fentanyl, particularly upon re-entry from incarcerated settings. But even within carceral settings, that mortality can really be significant. When people are experiencing opioid withdrawal, it is associated with increased risk of suicide. And so this is really one of those populations that when we think about having impact on the overdose mortality curve, this is one of those top priority populations.
And Dr. Potee, you are our boots on the ground in this conversation, actually working in a jail in Massachusetts. I wonder if you could tell us what are some of the challenges you have seen in getting treatment to the patients at your jail?
So I think folks know that when you're working in a jail, you're taking care of patients who have, by and large, high mental health diagnoses and huge substance use, whether it's alcohol or opiates or methamphetamines. 80% of the people at my jail are there with a substance-related crime. And if you're not actually providing them the treatment they need, then they're just going to recommit crime and cause harm to themselves and society. So it's absolutely critical that we have low barrier access. And the problem, for those of you who don't know, is you can't just prescribe methadone to a pharmacy and have it get delivered to your jail or prison. And thanks to the excellent work at SAMHSA under Ingvild Olsen's leadership, and this has been the best SAMHSA we've ever had, the rules were rewritten, and they added 3 words, and jails and prisons, to one paragraph. The same paragraph that allows a hospital to use methadone, jails and prisons in our country can now do that. It's amazing.
Dr. Olsen. So, I think one of the things that, as Ruth was mentioning, that we were able to clarify, actually, in the rule, an existing DEA regulation. And obviously, I can't speak for the DEA, but essentially that then does designate correctional facilities, so jails and prisons, as similar to hospitals when they have a hospital/clinic designation where they can provide both continue as well as start methadone outside of not having to have kind of that narcotic treatment program credential, not having to have the OTP credential from SAMHSA, as long as the OUD, the opiate use disorder condition, is secondary to another primary health condition, and secondary to a health condition other than addiction. So what that means, and the impact of that, is that can absolutely expand access to methadone treatment, not only for people who are on it in the community and then who get incarcerated, particularly in jails where there's just an incredible turnover and you just don't have time to really provide all the services that otherwise is available in opioid treatment programs, but also in prisons and as part of kind of an integrated health system. And so it adds another option in the toolbox for really being able to provide access to all 3 FDA-approved medications for opioid use disorder. And that added kind of having access to all 3 is so incredibly important. We know from research in Rhode Island and other places that when people have options, when they have the choice of being able to take the medication that they think is going to work best for them, that's where we really see the uptake of the medications for treatment and where you see the reductions in mortality. In Rhode Island, it was up to 61% reductions in mortality for people who were reentering into the community compared to the general population when they really had that access to all 3. So that is just, I'm just very excited about the potential impact of this. You know, the rule was passed earlier, released earlier this year, took effect, compliance date was October 2nd. So we have we're doing a lot of implementation work right now to really get the message out, not only because we changed wholesale, kind of substantively, really a lot of the pieces in the rule, but this one in particular, I think, is really an incredible opportunity to really be able to make a difference.
And because this is a public health conference where people are focused on science and outcomes, it isn't just outcomes related to overdose death. There's more studies funded by JCOIN and other federal government agencies on the 2 states, Massachusetts and Rhode Island, that universally have rolled out treatment in jails and prisons that look at a 40% reduction in recidivism. Those are huge numbers when it comes to recidivism. You don't see anything that changes the course that people's lives take once they're incarcerated once. So one of the challenges I would throw out at you is, do you know what your local jail or prison does for people with opiate use disorder? Most often people have no idea. Most often people actually have no idea who their local sheriff is. And your local sheriff, by the way, runs your local jail. And I would challenge you as public health people that care about people who struggle with substance use disorder, that this is the area, more than any other area, where you can alter somebody's life and outcome. And I would also argue that jails and prisons should be run by public health officials. You hire somebody who's in charge of security. You can do that, that's fine. But the reason I'm up here is because I have a sheriff who's a public health guy. And he said to me in 2015, I said to him, we need to get buprenorphine in here. And he nodded his head and said, you're in charge, you're the medical director, make it happen. And so we have been doing methadone and buprenorphine, and we're a fully licensed methadone clinic because I had the leadership of a public health-oriented human.
Dr. Poti, I want to stay with that for one more moment. It's not just access to the treatments, but people who are able to care for the patients in the facility. What workforce shortages are we grappling with right now that might affect this broader question of access to treatment?
It's hard to work in a jail and prison. I don't know who in this room does it, but there's a lot of moral injury when you work in a place like that. They can be dangerous, they can be violent sometimes, but for the most part, you're actually taking care of people who are your friends and neighbors and your kid's nephew. And when you are watching people suffer with either an untreated mental health diagnosis or an untreated substance use disorder, it is very hard to show up at work. And you know who supports treatment at my jail is security. They want people on treatment because it's much better for them. We have fewer disciplinary reports. It's less harmful for our correctional officers. They're safer. And so once you get real buy-in, it works. The problem is the pushback on buy-in is enormous. And when you're trying to influence an entire state, the state of Kentucky has 120 counties. They have 84 county facilities. Tell me how you're going to affect that state. State by state has got to say this is a universal required program in our state.
Dr. Olson, we have the federal efforts, many of which you're leading. We also have an influx of opioid settlement dollars that are reaching state governments, local governments, many of which are also trying to expand access to treatment in these settings. How is this all coming together? It's a bit of a patchwork, and what would you like to see for the next few years?
Yeah, so I can really kind of speak to I think what we've been seeing from the federal government and how we've been working with states around particularly braided funding. I think using opioid settlement dollars, we provide states with the state opioid response grant dollars as well that can be used, and many states are using those dollars also to help support access to treatment for substance use disorders in their jail settings. And this is a great place to really be able to actually combine federal, state dollars, local dollars, and have this evidence-based practice really be able to have a huge impact on communities.
And a final question to you, Dr. Pote, because we are out of time. I wanted to ask, President-elect Donald Trump has really focused on opioid use disorder and the broader opioid epidemic in terms of law and order more so than public health. And I know you just mentioned that all jails and prisons and incarcerated settings should be run by public health officials. What do you anticipate from the next administration?
I'm like the rest of you. I live in fear, and I'm also, I have a giant question. Having said that, SAMHSA rules take years and years to change and rewrite. So I think we're good there. Thank God for that. And then, the other thing about jails is they're hyper-local, and the federal government has no idea what's happening at your county jail, quite honestly. It's so far down their list of things they want to wreak havoc on. We may be okay. So let's make an impact on your local jail and your state corrections facilities. That's how we can do it. The Federal Bureau of Prisons is the largest methadone clinic in the entire country. So we already got the federal BOP on board, and they can't take that away.
And on that note, that is our time. Thank you so much. Appreciate it.
I'm Cody Engel, and I'm a Bloomberg Fellow. I'm also the Senior Research and Evaluation Specialist at Lost and Found, a Sioux Falls, South Dakota-based nonprofit committed to suicide prevention. We know that LGBTQ+ 2S people have increased rates of suicide, and that South Dakota is lacking in good data on that community. We're working to change that. In my work with partners across the state, I use data to tell the stories of how suicide prevention programs are impacting the communities they serve. At Lost and Found, my colleagues and I track emerging evidence and trends in mental health and suicide prevention to guide our work and focus on identifying the strengths and weaknesses of current systems. I'm proud to be the principal investigator on South Dakota's Inclusive Care Collaborative, an innovative project designed to enhance the overall health and mental health care experiences of queer people in South Dakota. Being a queer person who leads queer-focused research in South Dakota is really important to me. I understand how important affirming mental health care is for someone who is feeling isolated from the broader community. Through the connections I have made as a Bloomberg Fellow, I now have the skills and network needed to better deliver equitable, data-driven, and resilience-focused services for youth and young adults in all the communities of South Dakota.
Please welcome John Feinblatt, President, Everytown for Gun Safety, and Dr. Annie Andrews, pediatrician at the Children's National Medical Center, CEO and founder of Their Future, Our Vote, and senior advisor at Everytown for Gun Safety.
Annie, let's get right into it.
Sounds great.
So when Mike Bloomberg and I started working on the issue of guns, we really thought of this as a public safety issue, and that was natural. Mike came into office right after 9/11, and he wanted to make sure that people thought that New York was a place to live, to visit, and to invest. But one thing about Mike is he follows the data, and it became pretty clear that this was not just a public safety issue, it was a public health issue. And in fact, by 2020, if I'm right, guns became the leading cause of death for children and teens. And so the obvious question, Annie, is how do you mobilize the medical profession, particularly doctors, to work on this as they've worked on other public health issues like tobacco? So Annie, you're a doctor. Take us inside hospitals, take us inside of doctors' offices, and tell us how this issue is dealt with.
Sure. So when I became a pediatrician, when I decided to become a pediatrician, I envisioned a career caring for children with asthma, pneumonia, diabetes, and seizure disorders, and broken bones. I never imagined I would care for so many children who had been shot. But as you just said, gun violence is now the leading cause of death for children in this country, and this is a pervasive public health crisis. So you would be hard-pressed to find a physician practicing in any subspecialty that doesn't walk around with the haunting memories of standing at the bedside of patients who have been shot. For me, I will always remember a sweet 4-year-old boy who found an unsecured firearm on his coffee table, and as curious children do, he picked it up, unintentionally pulled the trigger, and shot himself in the head. By the time I met him, he had had multiple neurosurgical procedures. Part of his skull had been removed. He had to wear a helmet. He was in the hospital for months learning how to walk again, learning how to talk again, and learning how to feed himself again. And every child I've cared for who has been shot is a tragedy. And what keeps me going in this work is the fact that these are preventable tragedies.
So those are heartbreaking stories, and it would seem obvious that doctors should be part of solving this crisis. But there's a problem. And the problem is that this issue has become so politicized. And when I say that, I'm actually that's probably an understatement. Mm-hmm. And I think that one of the issues becomes doctors feel like there are political tripwires everywhere they step when it comes to the issue of guns. So about almost a year ago, I said to Annie, I remember when my kids went to the pediatrician and we learned about seatbelts and we learned about helmets when the kids started to ride a bike and we learned about how to secure the car seat. And so I asked Annie a simple question. How do we make talking about gun safety as simple and as straightforward as talking about seatbelts?
And that should be an easier question to answer, but we have learned that it is not. I think first I'd say that physicians in training, medical students, and practicing physicians are all eager to be a part of the solution to this public health crisis. We just have to provide them with the tools to do so. So about a year ago, I essentially went on a listening tour talking to anyone and everyone I could find in the healthcare sector who was engaged on the issue of secure firearm storage counseling, because that is a very clear, effective, cost-effective public health intervention to reduce the incidence of pediatric firearm injuries and deaths. And I stumbled upon, after talking to some of my colleagues at Cincinnati Children's, this incredibly innovative, scalable, standardized tool to provide education and a chance to practice skills for medical students across the country in partnership with the Mass Gen Center for Gun Violence Prevention under the umbrella of the New England Journal of Medicine. So I'm thrilled about the work that we're launching just next month, January 2025, at 10 of the top medical schools in the country, where we will be piloting this program to educate one-on-one medical students how to have nuanced conversations about secure firearm storage with patients and patients' families across the age spectrum and across the clinical spectrum. Because no matter what subspecialty a physician is practicing in, whether it's pediatrics, family medicine, psychiatry, trauma surgery, emergency medicine, this issue is so pervasive that it touches all of our fields. So we're going to be training a generation of new physicians how to have these conversations so that it is normalized, institutionalized, and standardized, just like it is to talk to families about the importance of bike helmets.
And I think it's important, Annie, to remember, we're not talking people into having guns or out of having guns. What we're talking about is safety.
That's right. Right. And I think what is so encouraging about this program that Everytown is supporting is that in the current political landscape, this is something that we can all feel really comfortable doing. This is a proven public health intervention that is completely separate from the politics of gun ownership and gun violence in this country. And I believe that's why medical students are so eager to do this, because it doesn't take you long when you're working in a hospital as a third-year medical student to stumble upon your first patient who has been shot. And as I said earlier, those situations are haunting, and we carry those around with us for our entire career. So of course, physicians are looking for solutions, and I'm just so excited that we can provide them, because
This is how we change the culture in medicine. It's easier said than done. Changing physician behavior is challenging, but when we use these scalable, standardized, innovative approaches, we can accomplish just that.
And if I'm right, for a hospital to participate, there's one requirement, that every medical student has to participate.
That's right. And so we're rolling it out in these 10 medical schools, including Hopkins and 4 historically black medical colleges starting next month. And we are asking the schools to commit to requiring one class of medical students to do this. So this is a 24-month pilot project that I know will continue to grow. We already have a waiting list of 10 other medical schools who are eager to have their students gain this knowledge and skill set.
Annie, it is so encouraging to work with you and to know that what we're really doing is building a new generation of doctors who are going to see the issue of gun safety no differently than they see safety, seatbelts, helmets, or the detergent under the sink, which was always the one that was hard for me because I never could unlock the safety lock that I put on it. Thank you very much.
Thank you so much, John.
I'm Michele Decker, and I'm a Bloomberg Professor of American Health and Violence. Gender-based violence is a leading preventable cause of injury and death. Survivors require social and economic supports to regain stability. In 2023, we had a major step forward at the federal level, the very first U.S. national plan to end gender-based violence. This is a blueprint for action that addresses prevention, housing and economic supports, and emergent forms like tech-facilitated abuse. This federal roadmap is a powerful tool. To fully realize its impact, we must institutionalize it at the state, local, and tribal levels, and invest in the monitoring systems for accountability and to track progress towards the goals of evidence-based violence prevention and response. These actions can save thousands of lives. Please welcome back Riley Griffin alongside the Deputy Directors of the White House Office of Gun Violence Prevention, Greg Jackson and Rob Wilcox.
Greg and Rob, we are going to be diving into some policy discussion moving forward, but I want to start with your personal stories. I wonder if you could tell the audience here a little bit about how you actually came to this line of work and how it's informed the way you think about gun violence through the lens of public health. Greg, we'll start with you.
Yeah, it was a pleasure to be here. And unfortunately, for me, my start to this work wasn't through ambition or application. It was through tragedy. In April 2013, I was caught in a shooting and was shot, and the bullet that hit me hit 2 arteries. And I came within 26 minutes of losing my life. And I'll never forget coming out of one of 6 surgeries in my 6-month recovery, but really that first surgery, and turning on the news and watching leaders in Washington refuse to take action because I was shot just 3 days after the failed Senate vote on universal background checks in the wake of Sandy Hook. And so that's where that fire really started to burn with me about how do we change things and how do we push Washington to do more on this issue.
And Rob, your story?
Yeah, so my cousin was shot and killed in January of 2001, making me like 54% of American adults who know someone in their family or friendship circle who's been affected by gun violence. She was on winter break from Haverford, volunteering at a local hospital when someone walked in with a gun who shouldn't have had it. I moved to DC to start taking action right out of college, and I was welcomed with a headline that said, with the election of George W. Bush, the NRA would work out of the West Wing. And if you think about progress, and I think about what we're here for, within 20 years, instead of the NRA working out of the West Wing, you had 2 gun violence survivors, 2 gun policy experts, leading the first ever White House Office of Gun Violence Prevention.
What a testament to your leadership. It's a novel office. We're just a little bit over a year into the office being formed. And I know you've put out a progress report. I wonder if you could tell me briefly what one key accomplishment you've gotten in the last year is that you outlined in that report, Greg.
Want to kick it off? There you go. Well, look, I think the big thing is that we ushered in the first ever public health approach to the issue of gun violence. Yeah. I know when I was shot, when I arrived at the hospital, I was met with investigators and law enforcement before I was met with doctors and surgeons. And in America, that's how we looked at this issue, as a crime to solve and not a public health crisis to prevent. But we've started to shift that, and whether it was the first advisory from the U.S. Surgeon General naming this a public health crisis, whether it's President Biden, the first president in history to name this as a public health crisis on December 21st of 2020, but more importantly, the interagency approach that we were able to build. We had 12 different agencies that played a role in addressing this crisis, over 54 executive actions, $30 billion in additional funds to prevent violence, and passing the first law on gun violence in 30 years. And so that all has greatly informed and impacted how we've attacked this issue. I do want to pass it to Rob, though, to share a few specifics.
Yeah, look, I think the biggest thing we did is we went from solving yesterday's crime to addressing today's public health crisis. And you do that by actually motivating folks outside of just justice and law enforcement. So we focused on the Department of Labor and their youth summer employment grants. We focused on pivoting the grant programs to help remove guns from domestic abusers. We focused on getting more data on gun violence. And we focused on the industry, honestly, who's been profiting to a tune larger than Nike on guns. And what we focused on were the bad actors. And so we shut down more gun stores, rogue gun dealers the past 2 years than the past 20 combined. And that's how we make progress, is we actually go at the problem.
Rob, this room knows how to follow the data, so I'm glad you mentioned data. For the public health community, they've often lacked the ability to have transparent access to data on gun violence around this country and those who are living with injuries. I know the federal government has access to some of that data behind the scenes, but what's it going to take to bring that to the public eye?
Look, you all are so important to this crisis because we're going to leave these seats in 50 days, but your efforts are going to continue. So one of the things we focused on from the very beginning was getting you better data, because we know we need to know where people are getting shot, injured, and killed, timely and local, so we can both implement solutions and measure progress. So what did we do when we started? Greg and I went to HHS. We said, you built a system to figure out when somebody sneezed across this country.
Right.
You telling me you can't tell me when someone got shot?
Right.
And so what they've done is use the hospital data systems, the same ones that were built for COVID, and filled those canals with gun violence data. So we do now have hospitalization data on gun injuries that has a 1-month lag down to the census tract. We have death data that has a 3-month lag down to the local level as well. And that actually gives us the first ever national picture on gun death and injury, so we can focus and target our solutions.
And I just want to reinforce, there's some really big findings in there. You know, we found that gun violence is the #1 cause of newly disabled Americans. It's the top 3 cause of death for pregnant women in America. We talk about how this is the #1 cause of death for youth. Only 1% of that happens in schools, right? So we're starting to see the full picture of what this crisis is. And we know that data can really empower you, as all of you are part of this movement, whether you signed up or not. But now you can start to see, okay, well, if this is the challenge in my community, like Intermountain Health, for example, where they're looking at, okay, how do we creatively get to older rural men that we are seeing surging in suicide? But with that data, we can empower this broader movement to think of new and innovative ways to solve this crisis.
And I think on the data, if I could just say, one thing in a limited time we have to tell you is that the solutions we put in place the past 4 years, we've seen success. And it's hard to measure success with an issue as painful as this, but last year we saw the greatest, steepest decline in gun and homicides in the nation's history, 13%. Which is amazing.
Yeah.
This year, it's 17%. City like Philadelphia saw a 50% reduction. City like Baltimore, over 40% due to the partnership of local state government, LifeBridge Health System, Safe Streets, right? These solutions we know work. And the question we're confronted with, are we going to double down on them, even without this office, or are we going to walk away?
Well, you've hinted at the elephant in the room, which is what becomes of this office in the next administration. And it might not be something that you can necessarily answer to, but I wonder how you'd like to see the torch carried.
You know, look, the previous administration was very clear that they did nothing on this issue. They even bragged about it. And we know that this is not a topic or a debate. This is literally our family, our cousins, our friends. It was almost my own life. Last fall, I lost my mentee to gun violence. Someone who actually came to Capitol Hill and fought for the Bipartisan Safer Communities Act was shot and killed in his front porch. So we can't expect them to carry the ball forward because they've already set their agenda. But what we're inspired by is all the work that we've laid out. Those 54 executive actions are a big deal. You know, now that Medicaid can be used for violence intervention programs and safe storage, adding $2 billion to the Victims of Crime Act, victim services, putting $400 million into community violence intervention, hosting the first ever convening of 60 health CEOs from across the country. Those are all, you can read them all in our report, but those are highlights of the critical work that we've done, and that work will continue to ripple as long as we have people to carry the baton.
And let me be very specific. We didn't offer a prescription on this issue. What we offered was a playbook. And we don't need the federal government to run those plays. Our state leaders, our local leaders, our health systems, our schools, all of us, our philanthropists can run those plays. And so we've published it all, and we just know that we need to get this playbook in action because that's what can save lives.
A final question for you, Rob. Given your work on the Bipartisan Safer Communities Act, what is the lasting legacy of that beyond what the White House is able to do now that we have this legislation in place?
Yeah, look, that was the first law to pass in 30 years. Time and time again, we failed to pass federal legislation. But what was the difference this time? Was it more Democrats? No. There was 50 Democrats in 2000, 50 Democrats in 2012, 50 Democrats in 2022. The difference was 15 Republicans joined with us to vote for gun safety because we have changed this issue. We have changed the politics of it. We've changed the policies of it. And so that law both set new standards for gun sales, closed the gun show loophole, addressed dangerous boyfriends who are convicted of domestic abuse, funded $15 billion. And when it was written, those $15 billion don't need to be appropriated. They already were. So we can keep investing them the next 2 years. And it's not just us talking about this law. Last week, the 3 leading Republicans who negotiated wrote an op-ed that said the Bipartisan Safer Communities Act gives us cause for optimism. So I hope that gives you cause for optimism as well.
We'll leave on a note of optimism then. Thank you so much, Greg and Rob, for your moving story. Appreciate it.
The White Mountain Apache tribe is on the Fort Apache Indian Reservation in the White Mountains on a beautiful 1.6 million acres of land. This is our ancestral land.
Celebrating Life was established to address suicides in the community because of the number of deaths that happened in the early 2000s.
Celebrating Life is one of the world's first community-based, mandated suicide surveillance systems. We very seldom are able to show through research decreases in both suicide attempts and especially suicide deaths. Those studies sometimes will be able to show decreases in suicide ideation or depression, but aren't often able to track suicide deaths like the Apache suicide surveillance system has been able to do.
Our staff serve as really strong case managers, and when we receive follow-up referrals, they go out and conduct follow-up visits. Once they make contact with an individual, we offer additional support for them, and we also connect them to additional services. More than half of my staff speak Apache, and they're able to do a follow-up visit completely in Apache. And when you're talking to someone and the words that we're using in our language, the meanings it's completely different than it is in English.
Everything we do is done with prayer. We pray against the negative that we fight spiritually in our job.
I'm working with this young man that was really struggling. The day that I met him, he said that if this lesson didn't go the way that it did, he said that if this was just another cookie cutter version of you trying to fix my mental health, he said, I probably wouldn't have been here the next morning. If you didn't sit with me and talk with me the way you did, I probably wouldn't have made it.
I didn't know that my granddaughter was hurting. I didn't see any signs. I always just assumed that we were okay. We're fine.
If you feel like somebody is not okay, ask them, how is your day? How are you? Even if they seem happy, still ask them.
We have to stand up and be strong to face whatever that comes our way. And we need to do that as a community. It's important because, it concerns our people, the tribe. We should think of our life as very important.
I hope that the future impact of the Celebrating Life program will just be to continue to reach Indigenous youth across the U.S. and across the world.
The staff's dedication to do everything to their best of their ability to support our people. That's why it's called Celebrating Life, because we want to be able to celebrate somebody's life.
Please welcome Dr. Mallory O'Brien, Associate Scientist, Center for Gun Violence Solutions at the Johns Hopkins Bloomberg School of Public Health, and Malcolm Cunningham, Bloomberg Fellow, Gun Violence Review Board and Director, City of Toledo Mayor's Office of Neighborhood Safety and Engagement, with Mark Talbot, Chief of Police, City of Norfolk, Virginia, in conversation with Chip Brownlee, reporter at The Trace.
Good afternoon, everybody. Thank you all so much for being here. I have been working at The Trace for the past 4 years covering gun violence. I write a lot about solutions to gun violence, and even though I do this every day, often I'm surprised by some of the solutions that I come across and really excited about things that we can work on. Violence reduction councils are one of those things. Mallory, you and I have talked about this before, so I want to go to you first. Can you just give us kind of a high-level overview of what violence reduction councils are and kind of how we got to this?
Sure, thank you. So violence reduction councils really are based in public health practice. The first violence reduction council was established in 2005 in Milwaukee, Wisconsin. It was called the Homicide Review Commission. And early in the days of the Homicide Review Commission, there was an evaluation that was completed that showed that in the districts that participated in the review process, there was a 52% decrease in the monthly counts of homicide compared to a 9.2% decrease in those not participating. So very quickly we went to looking at cases across the entire city. That was the very first Violence Reduction Council. Fast forward 20 years, and we're now in the next generation of homicide review, which is violence reduction councils. And we have been building out training and technical assistance on violence reduction councils based on lessons learned from communities across the country. What is a violence reduction council, which is really your question? A violence reduction council is really a framework for communities to think about how do we prevent gun violence. It's bringing together multidisciplinary agencies and entities to share data and information through a case review process that allows them to see what were those missed opportunities for us to work together and collaborate. And the components that I think are key for a Violence Reduction Council are having the right people in the room, having the right agencies in the room, having them really sharing not only their data, but information on how their agencies work, and how you in your own agency can see how you can leverage and work collaboratively with the other entities. Mm-hmm. The second thing I think that is really important is having really good data. And so if you think about public health, criminal justice, behavioral health, community-based organizations, community members that are participating in a review, you can imagine the magnitude of data that would be shared on a particular case. So being able to capture that information is really important, and so having a robust data infrastructure that underpins a Violence Reduction Council is very important. And then the last thing I think that's super important is having accountability. So having some accountability through having frontline individuals, mid-level management, and executive leadership engaged is critical, I think, to a successful Violence Reduction Council.
Yes, thank you so much for that. Chief Talbot, I want to come to you next. Violence reduction councils are really something that is implemented at the local level. And in Norfolk, y'all have had a homicide review commission, which is basically another name for the same thing. Can you kind of walk us through how y'all got that started and what kind of progress y'all have seen from that?
So I think the first thing that we had to do, given the somewhat anti-intellectual bias that policing can have, but that's okay because so does half the country.
No comment.
We had to get to the point where we're willing to think more completely and with more precision about what's driving crime. If you're, in other words, if your model of gun violence is it's all about bad guys or girls with guns, you ultimately don't get to the complexity that you need. So injecting ideas into the organizations that I've been a part of, talking about things like economic deprivation and marginalization and the impact in some communities of the compounded suffering, and how it's those communities that ultimately are generating a disproportionate amount of the violence. Once you start to look at public safety through the lens that allows for that complexity, now you can overlay a strategy similar to what was described and move the organization and move the city forward in reliable ways. So that's been really effective for us.
Could you talk a little bit about collaboration? Because one of the things I've talked to people working on gun violence in communities across the country, and one of the things that always comes up is, people often feel like their work is in silos, or they're doing something and they don't really know what the organization down the street is doing or what the police department is doing. Has the Homicide Review Commission, has that helped y'all kind of break down any of those silos and work on collaboration between the police department and other stakeholders?
It absolutely has. Policing, again, can be a closed society, and in the closed society that it tends to be, the language and the ideas aren't necessarily conducive to having great partnerships. You might not be surprised to know that we're not great hosts all the time. So having a structure and stakeholders that are sitting with us at the table and adding new language and new ideas has been very helpful.
Malcolm, what are y'all doing in Toledo? And could you talk to us? I imagine setting up a strategy like this can be difficult, and there's probably challenges that you encounter in doing that. And could you talk a bit about the technical assistance aspect of this and what you've learned from your work in Toledo?
Yeah, absolutely. We've received extensive technical assistance actually from Dr. O'Brien was standing up a Violence Reduction Council in Toledo. So she's come on the ground, she's met with us bi-weekly for the past year or so, and has been able to provide us guidance with setting up that data system that underpins everything, with determining who the right people are to be in the room with you, those key stakeholders, and has just been an incredible resource throughout. So it's been really critical to have her on board and to have the support of the Bloomberg American Health Initiative.
Thank you. Fundamentally, I think what everyone's trying to do is serve the community, right? I mean, at the end of the day, the point behind the Violence Reduction Council is to reduce violence. And I'm wondering, what kind of feedback have you all gotten from the community stakeholders that you're working with? I don't love the word stakeholder, but all the other organizations that you're working with, the people on the ground in the communities that are most affected by gun violence, have they given you feedback about this model, and what have you learned from that? Mallory, do you want to maybe start? I know that y'all did some feedback in Milwaukee.
So what we found, there are challenges. Information sharing is one of the key things that teams struggle with. But everybody that has participated feels like there's value in being in the room together. And even if you don't have every agency sharing information, getting them in the room and hearing the same thing at the same time and having them be part of the solution, people really appreciate having that ability to help drive some of the strategies. And they also appreciate that something is actually happening, that they see movement, that the strategies that are identified and developed are actually being implemented.
Malcolm? And with us, we know that lived experience is expertise. We also know that communities are often exhausted by planning, by meetings. So They've been able to engage and see that there is actual progress on the recommendations and that there's a willingness to convene across these different stakeholder groups. We have grassroots folks that have been on either side of the gun. We have the police chief that's involved. We have our public housing complex. You know, we have all of these different stakeholders that are just willing to support and engage. So they're excited about it. They're willing to move forward, and they want to see actual action happen. So
I'm curious if you have any thoughts on how you make sure you have follow through on the action aspect of things.
Shared accountability in a public setting and having a return to whatever those goals and those recommendations are. So that's really the key for us.
Chief Talbot, do you have any feedback?
Having having somebody at the table who is typing minutes and is helping to track agreements so that the folks who say that they're going to do something actually do it. I think very often our strategies and our approaches to reducing gun violence fails in the most mundane ways possible. You just didn't knock on the door. You didn't actually do the interview. You didn't actually build the relationship or follow through in that particular neighborhood, and it was simply a failure to honor one's word.
Mallory, really quickly, could you tell everybody, y'all have a toolkit that people can access to learn more about violence reduction councils. How can they find that?
We have, just Google Violence Reduction Councils. But it was funded through the Bloomberg American Health Initiative. It's a toolkit. We have training. We are supporting communities across the country. So if anybody's interested, reach out. But one of the things that's been really exciting is that because we've been doing this work now for some time, we were just awarded a grant from the U.S. Department of Justice to use the Violence Reduction Council model to look at multiple casualty shooting events that are occurring in our cities across the country. And looking at the intersection of these multiple casualty events and community violence intervention. So we will be piloting that in 5 communities across the country.
I think that's a great note to end it on. Thank you, everybody.
Please welcome back Dr. Joshua Sharfstein and Michelle Spencer.
Wow, what an interesting conversation. What a day. Are we there yet?
Well, you promised that it would be a Bloomberg American Health Summit like no other, and you were right.
We've discussed advancing public health in uncertain times with new approaches like analyzing court decisions, new programs like violence reduction councils, and new perspectives to finding common ground and reaching across partisan lines. I think we all deserve a round of applause.